Assalamu alaikum, ladies and gentlemen. I'm Dr. Fatima Zahra, Associate Professor of Medicine and Endocrinologist in Fatima Medical College and Executive Member of the Pakistan Endocrine Society. Today, I welcome you all to this session. The topic of today's session is type 1 diabetes, 100 years of insulin. To chair this session, I like to invite our worthy panelists. First of all, I like to invite the first honorable panelist, who is a very well-known pediatric endocrinologist, and he is the director of Institute of Child Health, and he was the ex-director of National Institute of Child Health, Jamal Raza. Kindly come to the stage and have your seat. Our next worthy panelist is Professor Basit. He is the director of Bakai Institute of Diabetes and Endocrinology, Joint Secretary Pakistan Association of Diabetes, ex-chairman of Diabetes Federation, executive member of Pakistan Endocrine Society. Now I'd like to invite our next worthy panelist, Professor Jamal Zafar. He remained a professor of medicine at Pakistan Institute of Medical Sciences, Islamabad, and currently he is the CEO of Hanif Medical Complex. Kindly have your seat. Thank you, sir. Thanks for joining us. Today's first talk is diabetes, the Pakistani perspective. Much needed talk. And for this talk, I like Dr. Atif Munir. He is the consultant endocrinologist. He's the assistant professor in Fatima Memorial College of Medicine and Dentistry, Lahore, and he is the executive member of Pakistan Endocrine Society.
Bismillahirrahmanirrahim. Thank you for the introduction and a very deep thank to the organizers and the scientific committee of society to finally have a type 1 diabetes dedicated session. 4 years to convince them, but here we are. Okay, I'm going to make a start. The piece of advice that helped me settle down when I relocated from UK back to Pakistan, and this was given to me by a person who I always go to whenever about something, and he said, there are 3 ways of doing things: good way, the bad way, and the Pakistani way. So I'm going to give you a perspective about type 1 diabetes from our point of view, from Pakistan's point of view. So I'm going to talk about briefly about the prevalence of type 1 diabetes. I'm going to briefly touch public and healthcare practitioner awareness about type 1 diabetes. What is our national response to type 1 diabetes? The world sees it, not as how we see it. A brief glimpse of perspective of people with type 1 diabetes who live in. A few words about type 1 situation and access to and cost of insulin in Pakistan. So let's start. So before we discuss the prevalence of type 1 diabetes in Pakistan, it's good to have some idea about what the trends are like worldwide. This is all from the IDF Atlas 2019. We know that the curve is due to be officially launched on the 6th of December. So type 1 diabetes increasing in many countries, particularly in those aged less. Overall annual increase is estimated to be around %, with obviously geographic and ethnic differences. Where do we stand as of now? As per the IDF, is the benchmark we use for prevalence and incidence worldwide. This is type 1 diabetes, and according to the world, we currently have about 6,000 people with type 1 diabetes. Show of hands, please. Who thinks you all look at 1 diabetes? I can see a lot of faces who've got major chunk of both as type 1 diabetes. Please show of hand who thinks these figures are anywhere near to what we have on ground. Not even a single hand. Okay. Then I extrapolated how is this data collected by the International Diabetes Federation. So very clearly, the vast majority was from peer-reviewed publication in National Health How many peer review publications do we have for Pakistan? National Health Service we have for Pakistan for type 1 diabetes? Not much. Data from other official sources such as health and reports from health regulatory bodies. Do we really think we have some type 1 as far as health regulatory authorities is concerned? I couldn't find one. If you do, please share. The MENA region, the Middle East and the North Africa region, this is where Sun is. It's a list of 21 countries, and we're one of the 20s. So when they did the last atlas, only 12 countries had an incidence data, a recorded incidence data. For the remaining 9, if a country did not have any information available, the incidence rates for ages under 15 were estimated by using data from a similar country based on geographical proximity. So our geographical proximity is to either to India, yeah. So as far as India is concerned, so the latest figures are, which are going to come out in the atlas, which will be launched on the 6th of December. The Pakistan now has about 8,000 people with type 1 diabetes. The incidence code is, well, the new cases per year is about 800 to 1,000. As compared, India has per year about 24,000. So 800 to 1,000 for us, 24,000 new cases per year for India. Even if you account for the population number difference, this is still undigestible for us as Pakistanis, because whatever data they've gathered from whatever we have is very small scale and virtually non-existent. So if I was an advocate for type 1 diabetes, I would have wanted that rather we had no data on type 1 diabetes, so that they could have extrapolated our numbers from our neighbors, and we would have had more numbers by then. So having data on a small scale sometimes can backfire, which is the case here. How do we move forward? We really need to assess the real scale of type 1 diabetes in Pakistan. A registry is a must. We can't wait for the government to produce a registry. Well, in that case, we will keep waiting. Be it provincial level, national level, health ministry, public-private partnership, and this is where Dr. Basit has very kindly taken the lead, started a process that really needs to move on with pace. The day the registry starts to populate and we hit 8,000, we can then formally write to IDF, look, we've passed the numbers that you gave us as our estimate. Please look into it again. And this is how we're going to get our numbers right, not only for us, but for the world to look at. So we really need these numbers to estimate our incidence, our prevalence, and to move health authorities for policy reshaping, changing. Without numbers, you can't convince anyone in this era, not even yourself. Obviously, when we get our numbers right, we will be able to conduct some research, showcase, do more work on type 1 diabetes. I applied for a grant a few months ago, and it was an international grant, and I was declined very politely by the fact that you only have 5,000. We've got grants coming from countries that have much more numbers than your country. We are sorry. Next bit, public awareness. We've got loads of stuff available out on the media. I am not sure why these adults can be replaced in these flyers by kids. We still think as a population, diabetes can't occur in kids. And we know where type 1 occurs. So there is lack and paucity of public awareness material when it comes to type 1 diabetes. This is the era of social media. We can use it a lot for type 1 diabetes to raise awareness. We've done some steps. I'll show you a glimpse of, but that's just a tiny drop in the ocean. I really want all of you to put more drops in. This is just one.
of September 2017 जब उमायमा हमारी जिंदगी में फाइनली आई है. उमायमा वाज जस्ट अ बिग चेंज इन आवर लाइफ. फ्यू मंथ्स बैक हम लोग कलाम साइड गए, बट यस जब हम लोग वापस आए हैं तो डायरिया और लूज मोशन हो गए, जो हमें लगा कि शायद दांत निकालने की वजह से होगा. और उसने पानी बहुत पीना शुरू कर दिया, तो लाइक हमने सोचा कि सडनली लाइक वेदर चेंज की वजह से होगा, क्योंकि गर्मियां भी स्टार्ट थी. बट देन शी लॉस्ट 4 kgs इन अ वीक एंड स्टार्टेड यूरिनेशन इन एवरी 10 minutes.
टाइप 1 डायबिटीज़ के जो सिम्टम्स हैं उनको बहुत सारे लोग मिस कर जाते हैं, क्योंकि बच्चों में किसी को ख्याल ही नहीं होता कि बच्चों में भी डायबिटीज़ हो सकती है. इन सिम्टम्स में बहुत ज़्यादा फ्रीक्वेंट वॉशरूम जाना, बहुत प्यास लगना, वेट का सडन लॉस, मतलब ये कि बच्चों का वज़न 1 हफ्ते 2 हफ्ते के अंदर अंदर जो है कई केजीज गिर जाता है, और बहुत थके हुए रहना. ये 4 वो सिम्टम्स हैं जिनकी आगाही हर घर में मौजूद होनी चाहिए, ताकि अगर किसी बच्चे के साथ ऐसे सिम्टम्स आ रहे हों तो वो उसको फौरी तौर पर टेस्ट करवा सकें और उसका टाइमली इलाज शुरू करवा सकें.
किसी ने सोचा भी नहीं था कि 1.5 साल के बच्चे को टाइप 1 डायबिटीज भी हो सकता है, जिसकी वजह से हमें इन सब सिम्टम्स को कुछ और ही समझते रहे और लाइक उसका केस इतना खराब हो गया. जब उन्होंने हमें ये कहा कि जी आपकी बेटी को टाइप 1 है और वो डे केयर की कंडीशन है उसकी, बहुत मुश्किल वक्त था हम लोगों के लिए. और उमायमा के शुगर लेवल्स कंट्रोल में नहीं थे, विच इज अबव 1200. जब उमायमा डायग्नोज होके हीलिंग की तरफ आई है तो डॉक्टर्स ने मुझे बहुत एक स्ट्रिक्ट डाइट प्लान फॉलो करने के लिए कहा. बट ये इतनी सारी कंफ्यूजन है, क्वेश्चन मार्क कि वो एक ग्रोइंग एज की बच्ची, शी इज ओनली 18 months ओल्ड, मैं उसके लिए ये चीजें कैसे रोक सकती हूँ. स्पैगेटीज नहीं खानी? हाँ जी खानी है. स्पैगेटीज बनाइए आज मामा. ये वक्त था जब मीठी जिंदगी मेरी लाइफ में आई और उन लोगों ने मुझे सिखाया बेसिकली कि अगर डायबिटीज आपकी लाइफ में कनेक्ट हो भी गई है तो इट्स नॉट द डिफिकल्ट टास्क, यू हैव टू मैनेज इट एंड इट्स वेरी इजी.
पेरेंट्स होते हैं, उनको जरूरत होती है सीखने की. फॉर एग्जांपल कि डायबिटीज के साथ आपने स्कूल किस तरह जाना है, आपने काम किस तरह करना है, आपने खेलना किस तरीके से है. सो ये तमाम बातें हमारी जो पीयर सपोर्ट है, जो हम लोग एक दूसरे से के साथ दोस्ती करके एक दूसरे का सहारा बनते हैं, उसका हिस्सा है.
Puncture. Strip. What is this? Meter. 1, 2, 3. लग गया. Can we get a pet?
Okay, so I'm going to skip it for the purpose of time saving. Let's move on to the next bit. Healthcare practitioner training to diagnose and manage type 1 diabetes. Why? Because as per evidence, 30% of children may present with DK as the first presentation. So you need to recognize the symptoms of the healthcare practitioner early on. The dietary advice with a very heavy heart. The sort of dietary advice that is being given to type 1 children, not everywhere, is no different to type 2 dietary advice, which is an absolute mayhem. There are centers who are doing an excellent job of giving specific tailored type 1 dietary advice. But on the whole, if you look at the diet charts, the same diet charts that we have for type 2 are being handed over to parents of children with type 1 diabetes. Imagine what comes afterwards. A person with type 1 diabetes needs a lot of our time, counseling, support, because you're not treating a person, you're treating a family. You give 15 minutes or 10 minutes of a consult to a patient or a person. You can't give 15 minutes to a family. They need more time, they need more expertise, probably they need a bigger team. Peer support, more that I or you look after, think that they are the only ones in the that have type 1. Because they just have never met anyone else with type 1, think that they are a rare breed and they are the only ones with type 1. The concept of peer support comes in, which is still in its infancy. It's growing, alhamdulillah. We replicate our conferences and the styles to the formats of international conferences and societies. When was the last time we had a CME type 1 in this country? When was the last time we had dedicated to type 1 in this country? I don't know either. Our national response, not as how we see it, organization sees it. In 2016. Not sure which column, Prof, but there has been work done since then. We've got some type 2 guidelines coming up, but coming up won't change WHO. The WHO books will change when it comes up in the our health authorities, because the records that are screened on these parameters are government records, are public health records who penetrate into public health with the government to improve our services and then provide the data to them, so it will change. This has to change. Word about what do people with type 1 think about their condition, about one as a whole. Rather than me going on about it, just watch this video. This is from Metron Campaign to raise type 1 diabetes awareness through the life of person with type 1 on a daily basis.
Type 1 diabetes. It's something you do in daily life, but while keeping a balloon in the air. Next thing to explain, even to the people who know us best. Downs of life with diabetes. It can be challenging. Own ways of living with diabetes. And most of us handle it, but it's invisible to others. It is always there. And it's time we start talking about it. Together, we can make a difference.
Okay, so just to highlight this, I did this study. I won't present the whole study that I'm presenting. So I did something about quality of life, diabetes in Pakistan. Just briefly go through the results. It's a cross-sectional study. We've got responses, which was fantastic. We've used this questionnaire, which is a valid one, and it covers the following 4 domains to assess quality of life. I'll just show you some, just reflect on what's happening on ground in Pakistan. So the demographics, as you can see, most were university students, 70% age group, etc. And let's look at some. I mean that it's a Likert scale. It's, disagree, strongly disagree, and 5 is strong. So I feel satisfied with how I deal with my diabetes. You 60% who feel satisfied. What about the 40? We need to think about those 40%, the big chunk. I feel satisfied with my current level, HbA1c. About 55%, 45%. Isn't it our responsibility to think about those 45%? I feel well physically, okay. About well physically Okay, what about 30%? Are they not our responsibility to do better? I feel well psychologically. 45%. What are we doing for those 45%? The last question was, which was my addition to this question. Education program for type 1 diabetes in Pakistan will empower you to live a better life. Look at the hunger that's there. So we really need a type 1 diabetes locally tailored structured education program. It was done it. The world has shown it. If you do a structured education program, you well-being, psychological well-being, you reduce decay admissions, etc., etc., etc. We don't need the government to do this. We can do it. We are endocrinology. What are we there for? Last but not the least, and access to insulin in Pakistan. Some stats. Poverty in Pakistan has increased from 4.5 to 5.4. Minimum wage is 15,000. Human insulin costs, well, the cost is WHO still thinks that even insulin is not just, this is whole of diabetes, not just exclusive type 1. WHO in their figures and stats has these records that insulin is not even generally available in our country. And put your hand on your heart and please agree that yes, to some extent, yeah, fine. So, title of this year's World Diabetes Day fits in well. Type 1 diabetes in Pakistan. If not now, when? But to start a journey, you need to take that first step. And steps. We have taken some good steps individually and collectively, but we need. So what can we all do in our individual from trying to gel together? We can do lots. You can do lots. Stops you from making noise. Yes, we need a registry. Hats off and his efforts. We've got a registry. We need to fill it up now. With the cohort that I look after, you will fill it up with the cohort that you look after. 8,000. Trust me. And when we have that 8,000 number, which ID cross it, 8,000 first patient enters, I'm sure the behalf will write to IDF and advocate. Here we go. Rethink. Who stops us from having leaflets, banners, interviews, sessions, talk shows? We've done lot T2, and we have done lot T2. Outcome 4th, from 4th to 3rd. Please accept approach has failed. I don't know whether we have to go to number 1 to tell us this. I don't know. Let's give some time to T1. We need courses, we need conferences for healthcare practitioners. General practitioners have always seen more type 2 and type 1 than us. They are seeing more type 2, type 1 than us. They will see more type 2, type empower them. If they want to refer someone for tertiary care, that's good, but connection with them, the T1 connection. Type 1 guidelines, yes, but that's not the first thing we need. Community advocates on board, it works. They have this very strong on around the world, lots of campaigns, nothing about them, they are a real force. You have no clue what force they are. Use them. We have a lot of them here in our country. Numbers, we need numbers first, then the noise, and then the advocacy to make health note. You go to them with 5,000, 8,000, you will have a cup of tea, you will come back, file closed. With national type 1 structured education models, programs, it's doable, it's doable, it's doable. I'm going to show you in a 2 months' time how it's done. We need to go through the basic diabetes checks because foot screening, retinal screening, where we stand in pieces, we are doing it, but it's not getting documented and the document reaching the health authorities. That's why it's not making its way to WHO. Last but not the least, I've got all the pharma world who gives us the insulin. We want to reach out to you. Think about it. Can you subsidize insulin, at least for type 1? We've only got 8,000 as per official figures. We've only got 8,000 kids and teenagers with type 1. Providing some sort of subsidy to them on insulin won't bother any of your profits, really, because your main profiteering thing is your type 2. Type 2 is rising. You can make more profits from there. For type 1, think about it, please. Won't cut your profits. It will raise your stature. And I end on a note, let's join hands for type 1 diabetes in times to come, and we can make real progress. Impossible is nothing. Thank you very much. Time.
Explaining very well about the role of multiple individuals, family, society, and educational institutes in the control of diabetes. Now the house is open for the questions. If there is any question from the audience. Do we have any questions? No. Okay. We will move towards.
Beta, Fatima, question hai wahan pe at the end.
I'm Dr. Shoaib. Thank you, Dr. Atif, for the excellent thought-provoking talk. You talked about insulin subsidy from pharma companies. I mean, in Pakistan, there is this insurance-based Sehat Sahulat card. I don't know if Pakistan Endocrine Society has tried to talk to them about this because there is a room. Because if there's only 8,000 patients, this is not going to be a lot of money. And that could really, give us universal coverage in terms of insulin.
I think on the question of has the Pakistan Endocrine Society talked to them, I would leave it to our president if he's around, because he's the flag bearer of Endocrine Society. To the best of my knowledge, no. But there might be few things going on. There might be few negotiations underway. There might be some MOUs in the pipeline, but the president would be the best person to answer.
All right, Atif, can I make 2 comments? Excellent talk, and we agreed that it has to be thought-provoking, which it is. As regards the Diabetes Registry of Pakistan, I only got the confirmation yesterday from the ministry that it has been taken on board and it will be under NIH umbrella very shortly. So Diabetes Registry of Pakistan will be a national registry owned by the government, inshallah, very soon. This has been officially given in mail yesterday.
That deserves an applause.
The other thing which you were referring to as the numbers for type 1 diabetes, I have been sitting in IDF Atlas Committee for the last 4 years. Unfortunately, they only have access to what is there. So the only study of incidence of type 1 diabetes was done in 1994. So when you look at incidence or prevalence of type 1 diabetes, they ought to consider that study and then look at the geographic proximity, etc. Jamal Raza sitting next to me will bear me out that Life for a Child asked us to do an incidence study. We identified the areas of Larkana and Sakka because there the population is staying there for ages and will hopefully continue. And for incidence study of type 1 diabetes, you ought to have a population which stays there for 5, 10 years, 15 years because of low incidence. But it is just when the MOU at SACRA was signed, COVID came. So for the last 2 years, we have not been able to do it. But this is something, unless you are able to do it, you cannot change the numbers. As regards the final point that if we have the registry and we show the numbers that these many type 1 are already registered, that will also not force IDF to change the numbers. IDF will only change the numbers once the scientific evidence is there that how many type 1 incidence rate is there. Thank you.
But yeah, agreed. But what I meant was then when we show these numbers, at least they can endorse and support us to do that study because it will be a large study, we will need grants, etc., etc. Point well taken. Yeah.
Yes, here's the question, Mike.
That context, I think two things are very important along with the medication.
Yeah, thank you. You make an absolutely valid point. It has to be a multidisciplinary approach. There is definite role of psychologists. There is a definite role of nutritionists. But please also note that nutrition has to be trained first. You need to train the trainer first. You can't have a nutritionist sitting in your clinic and giving type 2 advice to type 1. It's best not to have a dietitian for type 1 if you haven't got a trained dietitian. Someone has to train the trainers. Otherwise, just hold the hand of the type 1 yourself for each and everything. You will do a much better job. But yeah, it goes without saying that it has to be a multidisciplinary. As far as Daphne is concerned, just watch out. In 2 months' time, you will see the Pakistani version of Daphne being launched, inshallah.
Thank you. Now the next talk is best insulin regimen for type 1 diabetes, evidence versus experience. This talk will be delivered by Moderator Professor Tasnim Ahsan. She is the director of Medical Institute of Diabetes and Endocrinology, and she was the ex-director of Jinnah Postgraduate Medical Center. She is the one of the founding member of Pakistan Endocrine Society and mentor of many internists and endocrinologists. I am also the one of them. She is the secretary of Executive Committee of Endocrinology at CPS. Now I'd like to invite her for her talk.
Thank you. Assalamu alaikum. This hall, Dr. Atif Munir has in the next 20 minutes, I will try and cover the topic in a more general. So, when insulin was discovered and they gave it to the dog, had things happened, and then the first patients, there was a hall full of children dying of type 1 diabetes, administered insulin from one end of the hall to the other. And by the time they got fit, these children started regaining consciousness. And people thought, okay, we have conquered type 1 diabetes. However, this is not. However, that to be the case, what we basically did was that we stopped people from, no, the slide is not moving. From dying of an acute illness. It was a sure death. The life expectancy was not more than 2 years. And this life, so a life where starvation was used to kind of lower sugars. And one, the child looked like that. However, what we have now ended up doing is that we saved life with that very short life expectancy and transferred this acutely fatal disease to a chronic disease fraught with all kinds of complications, blindness, amputations, cardiovascular disease, and a shortened life expectancy. We saw that yesterday also. So the hallmark of type 1 diabetes is absent or near absent beta cell function. We all know that. For the past 6 to 7 decades after the discovery of insulin, we gave a twice daily injection. But things began to change about 3 decades as a result of the evidence that came along as a result of what very conducted elegant studies, and which basically suggest intensive insulin replacement as the best treatment. And this intensive insulin replacement can be done with multiple daily injections of insulin or a continuous insulin infusion, which will be covered after my talk. The ideal insulin regimen should basically mimic physiology, and that is stay in a blood time, minimize the risk of hypoglycemia, so dips in 70 are avoided. Non-physiologic regimens can be used initially. I want to think because this is where people kind of lose track, and that diagnose patients with type 1 or LADA adults may do well on OD and ORB insulin only before they progress to complete beta cell failure. And this time varies, it is longer in adults versus children. So this is because of the honeymoon period, and here is where overt diabetes starts, where only about 20% of function is remaining. And once you start treating it, the presentity is removed and it improves for a while, but eventually they do get to virtually no insulin secretion. So evidence for best insulin regime for this patient population is not clear. What is the best way of giving them insulin? But you can give them basal insulin, and you can give them the intermediate acting injection twice a day, or you can give them the analog once a day basal insulin like glargine or one of the other analogs. The physiologic insulin replacement looks like this. We all know this. Replacement of both prandial and basal insulin is required in patients with severe insulin deficiency. And here again, you can use an analog insulin. So Lispro, which is aspart, Lispro or aspart or glulisine, and then glargine and the other newer ones in that category, U100 and U300, and as well as the Ryzodeg insulin. And there is a new insulin which is in phase 2 trials, the once weekly basal insulin, Ryzodeg, which may make life slightly easier once, if and when we can get hold of it. The simple calculations, approximately 40 to 50% of the total dose given as basal insulin. The remainder is given as prandial insulin, and you start with a dose of 0.2 to 0.4, and most people will require between 0.6 to 0.7. Type 2 requires much more because of insulin resistance. And there are periods in the life of a type 1 child or an adult where the requirement is much more, which is adolescence. And we had a very nice talk yesterday about the adolescent factors for this happening, puberty and pregnancy and infection and so on. You all know that. So you need to adjust the dose upward during this period. Long-acting insulin can be given at bedtime or morning. We're used to giving it at night, but that doesn't have to be. So with the newer analog insulins, it's much easier and much better to actually give it in the morning. And 2/3 of the dose is best when you're using NPH, and 1/3 at bedtime. The pre-meal dose is, of course, determined by pre-meal blood glucose level. And here lies all the complexities of education and meal size and content and carb counting and glucose trends if you're using it CGM or if you're using multiple pricks to do that, and activity and exercise pattern. So if you're using NPH insulin, because there is a peak happening around lunchtime, if you've had it in the morning, sometimes you may get away with not needing some prandial insulin at that time. But I would advise, this doesn't really get you the targets. You really need some prandial insulin, because for us, lunch is usually a heavy meal. With effective carb counting and estimates of fat and protein content of the meals can also be incorporated, and you can further fine tune for gaining further benefit. Do not prescribe pre-mixed insulin for type 1 diabetes, ever, because you cannot deliver what you've set out to deliver with this kind of insulin regime. So this is just, I'm not going to go through this. You need to do bolus dose adjustments and calculate the insulin sensitivity factor, and then calculate the insulin carbohydrate ratio. You the dose of the prandial insulin that needs to be injected for that. Not very easy to do. So the whole business of giving insulin in type 1 diabetes, or indeed for type 2 diabetes as well, cannot be comprehended, you knowing what is the level of blood glucose you're dealing with when you're injecting with insulin. So SMBG is something that hand in hand with insulin injections, and it is an end of the therapy, and this can be done before meals and at bedtime. And there can be additional testing on many of these occasions where, before driving, exercise, when you suspect a hypo, or 2 to 3 hours after a meal. Continuous glucose sampling from the interstitial fluid. I'm not going to talk about it because I know that Dr. Abbas Raza is going to deal with it in a bit. So this is very recently we had the Freestyle Libre come in, and people are using it, and life has been made easy for them. Not just for them to understand their day and glycemia and what they're eating or exercising and what's happening to their sugars. It is for the first time that we, the doctors, are also learning to look at these curves and help our patients with, variations in their treatment, eating patterns, lifestyle, looking at it. So where did we derive all our numbers, and how did the practice change in the last 3 decades? Basically, for type 1 diabetes, this information came from the landmark study, which was initiated in 1983. Ran from 1983 to 1993. And this is the diabetes control and complications trial. And here about 1,400, over 1,400 patients were selected and randomized, and they were randomized into a primary prevention cohort and a secondary prevention cohort. And here the diabetes duration was, of course, shorter, 1 to 5 years, and here it was 1 to 15 years. And they had some more complications as compared to this group. So they were divided into, both the groups had an intensive and a conventional treatment where they were treated like by their own physicians, the way they would be treated otherwise. And this trial was terminated prematurely because the results were clear, the benefits were clear, and then the two groups were, so what was that? The intensive therapy in the reduced the early stage of microvascular complications by 34 to 76%. So this then, after that, the two groups were merged and put together, and the group that was on conventional arm was given the training that the other group had to be able to deliver that kind of care, and have them both return to their care with instructions about how to manage their diabetes. And subsequently, the epidemiology of diabetes interventions and complications study took over, and which has, gone on for 38 years. And this has given us very valuable information as well. So this was just an observational follow-up of the DCCT cohort. All participants were taught intensive therapy, like I said, and returned to their own healthcare. And 28 years on, the mean HbA1c here was approximately 8% in both the original group as well as the conventional group. And lo and behold, there seemed to be a metabolic memory. We keep talking about this, and this is so important. It has taught us that it is very, very important to get hold of that diabetes from day one, because of this thing, the metabolic memory. The damage that is caused initially is something that the body remembers, and the track for these two groups remains separated with regards to complications. The important thing to remember is that in the DCC trial, they did not use analog insulins. They used the regular insulin and NPH. And the HbA1c outcomes improve with intensive insulin therapy given by multiple daily injections or the pump therapy. So this is what it looks like graphically, and they were able to, they started with an HbA1c of around 9, and they were able to open out a 2% difference in HbA1c between the two groups before the two groups were merged. And then thereafter, they kind of followed the same pattern. So here in the conventional group, the HbA1c was 8, and in the intensive treatment group, the HbA1c was nearly the same, 7.9%. So a very long period of study. And here, I'm just going to look at some of the conclusions. So in terms of retinopathy, in the intensive treatment group versus the conventional treatment group, reduced eye surgery by 48%. Nephropathy was reduced by 50%. So well worth doing. Cardiovascular outcomes, the major MACE was reduced by 57% after 17 years. And as you know from yesterday's talks, the major killer is cardiovascular disease. So HbA1c is, and the other thing we learned is we keep talking about, don't be just glucocentric, but you have to be glucocentric because there is evidence for that. But that does not mean that you forget all the other things that go with diabetes. So you watch your sugars, but you watch your blood pressure, weight, dyslipidemia as well. HbA1c emerged as the most powerful risk factor after age. So we learned yesterday, if you were watching the talk, very nice talk yesterday, that the younger you are when you develop your diabetes, less than 10 years, the worse the prognosis long term. Mortality in the intensive treatment versus conventional treatment group, there was a 33% reduction. And effects of mean blood glucose levels, mean HbA1c during DCCT remained tightly associated with the risk of complications. So sugar is important. The sugar levels are important, and the metabolic memory. So despite narrowing of differences in HbA1c during edict part of the study, the observational part of the study, effects of glycemic exposure during the DCC persisted for approximately 10 years. So they remained divergent with regards to their complications. What about analog insulin and recombinant human insulin? The rapid-acting and long-acting insulin analogs have been developed over the last 25 years. And I remember when they were being introduced, they were basically being introduced as convenience insulins, because you don't have to wait for that half an hour, 45 minutes before you inject. But they have a distinct pharmacokinetic profile compared with recombinant human insulin. Similarly, basal analogs have been developed. And I just, the one in the pipeline at the moment that we should be watching is the once weekly, longer duration of action. And that flat profile is very helpful, because the midnight or the early morning, not midnight, but early morning hypos, that is the bane of a diabetic's life, or a patient with diabetes, type 1 diabetes or type 2 diabetes life is much reduced with this analog basal insulin. So what we learn from these analogs is that treating type 1 diabetes gives you slightly lesser hypos, slightly less weight gain, and a slightly lower HbA1c versus recombinant human insulins. But these are all slight differences. They can be overcome with the cheaper insulin. And remember, DCCT, they used the regular insulin, the regular human insulin. So what about the intermediate acting and the long acting basal comparison? So this is a meta-analysis of 39 studies, 27 randomized controlled trials involving 7,496 patients. The long-acting insulin is statistically significantly superior to intermediate-acting insulin for glycemic control as well as for harms, that is weight gain and severe hypo. No surprises there. If you look at the pharmacokinetic profile, you can deduce that. But again, it is not an absolute no-no for regular human insulin. You can still work with that very easily. No statistically significant difference in micro or macrovascular complications and all-cause mortality. And of course, we know that these are costlier insulins. So here's a slight difference that has been seen. So a difference of between Datamere and NPH of about 0.3% or something when you use it long term. We have even faster acting insulins now available with the compared with rapid acting insulin. So FIASP and Lispro A, B, C may reduce prandial excursions better than rapid acting insulin. And here is a curve, and this is the faster aspart or FIASP, and this is the rapid acting insulin curve. So you may even have a more elegant insulin there, which is controlling the glycemic excursion, which is, again, ever since we got the data from the pump, we learned that it's not just the HbA1c, it's the glycemic excursions that are also very important. So you can see that the glycemic excursion is lower with the faster insulin. And again, timing of administration of faster insulin, whether you give it after a meal or just before a meal. So faster aspart post meal doesn't work as well as the faster aspart pre-meal. In fact, it works than the rapid acting version. So I'm not much about the pump therapy. Pump therapy, if I were to have diabetes today, and if I had the money, I would want the pump. Pump works better and better and better now. So it's almost like a artificial pancreas, which Dr. Abbas Raza is going to tell us shortly. There is no consensus about what pump, who are the patients who should receive the pump, although there are some, guidelines. And the pumps have particularly helped with the hypos, but we have the issue of there's a lot of education required. You need money first of all, and but it can be done. So I have had pump education. We actually wore pumps and learned it works, but it didn't. I couldn't give it to many patients. Inhaled insulin, I won't talk about. It's just licensed for 2-year use and can work almost like rapid acting insulin, but there are pulmonary toxicities, and that is what limits its use. Surgical treatment of pancreatic islet cell transplantation is only a reality when a renal transplant is being done. And of course, if you could transplant the pancreas, it could, and it's working, it makes life very easy, but there is the issue of lifelong immunosuppression and graft rejection and recurrence. But if there is a kidney transplanted, then you may as well transplant that. So this is the new drug, the new kid on the block, which is the first drug which is in phase 2 trials, has shown the ability to prevent diabetes in relatives of patients with type 1 diabetes who are showing the antibody markers. This drug has shown that you can reduce the number of the blue curve is the teplizumab, and you can show that the number of people who develop diabetes as compared to placebo was less. So first drug in the pipeline for the prevention of type 1 diabetes. A little word about adjunctive therapy. Insulin, does not add much value when given to type 1 diabetes patients. And here is a study with cardiovascular risk, and they looked at things other than slight weight loss. There was very little cardiovascular benefit for adding it. Pramlintide, or the amylin analog, suppresses glucagon secretion, delays gastric emptying, and promotes satiety. And this is the co-formulations of amylin and insulin are in current development, and they're actually being used or considering it for the pump as well. So this is licensed for use in US but not in Europe, and this is a pre-meal injection. GLP-1 receptor agonist, we heard about it the other time. There are 2 situations where you could particularly use it, knowing the mechanism of action, because it preserves the beta cell. So you can ameliorate beta cell decline at the time of diagnosis. And there are ongoing trials at that. And then you can add it as adjunctive therapy for blunting glucagon secretion and all the effects of the GLP-1. So clinical trials of GLP-1 liraglutide at 1.8 milligrams showed an approximate 0.4% drop in HbA1c, and but it increased the rates of hypos and ketosis, and you need to be, and if there is some residual C-peptide, the results are better. It has CVD benefits in type 2 diabetes, but we do not know whether this can be extrapolated to type 1 diabetes. So it may have some role in those who have concomitant obesity. SGLT2 inhibitors we heard about yesterday. Dapagliflozin and sotagliflozin are licensed in Europe, but not in USA. And they also reduce HbA1c, they improve the time in range, decrease body weight, improve blood pressure, but have increased the rate of decay and euglycemic decay. So that can be problematic. So insulin dose adjustment is required in insulinopenic patients, and start with a low dose of SGLT2 inhibitors, and ketones should be monitored. So this is the chronic care model. I'm not going to go into any detail for this. This works for any chronic disease. And I urge everyone here to go back and read about the chronic care model and find your, for lack of a better word, jugaad solutions to the chronic care model. And you can find it wherever you're walking. Find components of this chronic care model to work with diabetes in your thing. So I really need to abbreviate my talk on reality, because Atif has covered it so brilliantly. So if we think we are covering type 1 diabetes, we're not really. We're just giving a really piecemeal, very little care, just prescribing insulin. And there are multiple reasons for that. So there are patient factors. Again, Atif has gone into it, so I'll just go through that. The general illiteracy doesn't help, and the health illiteracy. We are a nation that places very little value on health. And then, so how do you educate a population like that when you have, confronted with both these issues? The first and foremost, inability to afford insulin. I believe in KPK. Anyone who has type 1 diabetes gets free insulin. I can't understand why every province can't do that, for type 1 diabetes at least. Then there is this injection to resistance to injecting insulin, resistance to frequent injections. So you have to negotiate the number of injections that can be given, and we know what works, what there is evidence for. Then even if they give, accept insulin, they don't monitor. And there's, I'm just about done, lack of regular follow-up. So, they will come after 6 months, no control, nothing, no mechanism for chasing these patients. And this diabetes distress, it has been talked about, raised from the audience as well. This is something that we don't understand or don't try to deal with at all, but it is immense. We need to hold their hand and help them. And, in the long run, everyone gets fed up with all this, drill in their life. And the issue of adherence and perseverance and trying to bring back these people onto the straight and narrow path. So the stigma we've talked about, lack of community support and engagement. The stigma is huge, by the way. And there's, I just sat in with a group of type 1 diabetes advocacy group, and it was heartbreaking to listen to their stories. We all know them anyway. There's a lack of peer groups. There's a lack of advocacy groups. So society is not engaged. The healthcare services channels, the clinical inertia we all know about. It looks like this in one of the best healthcare systems in the world, the NHS. This is for type 2 diabetes. Situation is no different for type 1 diabetes either. There is lack of psychological support for there is diabetes. I'm so glad that diabetes registry, and I'm heartened that you've just confirmed it. I had a conversation with the health minister recently, and I said to him, you have done such a brilliant job of the COVID registry. Why, now you know how to do it. Just ride the non-communicable diseases onto this registry. And he told me, we are doing it, we have institutionalized it, and NIH is owning it now. So this education, I'm glad Atif is working on it, and at the foot is a forgotten place, actually. So I would like to end with this very nice paper from Basit's team, Insulin My Life, that he mentioned just now. So this is a bit like the DCC study. They had people who had been trained in diabetes from their own center. They recruited 1,428 patients. So Basit was able to recruit for a study 1,428 patients. And here is your Dr. Atif's, premise that this number is ridiculous. And these patients were kind of kept in the study for 3 years, and they were chased on an electronic databases. Everything was all good. There were monthly consultations. Everyone went through a 3 days workshop for educators and doctors. And they even went ahead and educated the teachers. Free insulin and all related material was given, and subjects were categorized into 4 different groups. Less than 5, more than 19, and 2 groups in between. And with all this, this is what they achieved. So I've just put the range of the groups. The mean baseline was 11.5 to 9.6. The higher values is in the younger patients. And after 3 years, this is what they ended up, about a 1% or a little less than 1% of a difference, more in the older patients as compared to the younger patients. So this is the kind of work we need to do, and I'm sure it is doable, and I'm sure everyone who gets up from this session will be motivated to, do their own bit about it. And the registry is, where it needs to start. Thank you very much.
Very informative talk by the madam. Any question from the audience? We can take only one question.
Assalamu alaikum. My name is Dr. Sulaiman. Ma'am, as you said that pre-mixed insulin shouldn't be used in type 1. On the other hand, if we look at the data, it shows that intensification, by intensification, we can improve the microvascular complications, or we can prevent them. I think as if we compare NPH with premixed, so premixed is, I think, more potent, and we can intensify the treatment with premixed better as compared to NPH. So what is the reason behind this?
Not to use the premix?
Yeah.
Because if you look at the evidence, you're matching food intake, activity level to the prandial insulin, kidney, and the monitored glucose level at that time. You cannot do that with a premixed preparation. And premix यहाँ क्या use होता है? अगर आप human insulin लें, it is 70% basal insulin, intermediate acting, and 30% prandial. You give it 2 times a day. You're giving 70% basal insulin and only 30%, whatever the dose, only 30% prandial insulin. That's not physiological. So अगर मैं ये समझती हूँ कि if you can negotiate 2 injections with patients, right from the word go, you can negotiate 4 injections as well.
Ma'am, you said we can give NPH. So I think premix is better than NPH.
Premixed is, I just told you the reason why it's not better. NPH is intermediate acting insulin. So for the type 1, for type 2, you may get away with this premix. But for type 1, you cannot get away with premix because you're trying to match everything to that prandial dose you're going to give with a basal.
Isn't it better than NPH?
Sorry?
Premix is better than NPH?
There is no comparison. They're 2 different things. You're matching oranges and apples.
No, ma'am, you said NPH can be used twice a day for type 1, but you can't use premix.
I think
Okay.
मैं sorry थोड़ा सा
in between. Otherwise, it doesn't matter. It's a genetic active thing. Basal insulin, the basal bonus is much better. You see the DCCT trial, whatever trial you are. So, madam is right. It doesn't matter what hour, and that's a problem. We think, okay, it's experience. The consensus or your experience is the lowest level of the evidence. You need to think about randomized control trial. And on that note, I would hand back to the moderator.
Can I? Okay. I was given a mic. Can I make just one comment there? Thank you. Madam, thank you very much for such a wonderful talk where we talked about different insulin formulations. We obviously talk a lot about different sophisticated insulins, and we have altered the insulin molecule, which Madam has kindly shown about ultra fast acting, ultra long acting. And I was just thinking about the comment by one of my trainers who once made that this whole insulin giving mechanism is flawed, because insulin giving subcutaneously is flawed. It's not just about monitoring the glucose or controlling the glucose that comes from eating sandwich, but actually 2/3 of the insulin comes from endogenous hepatic production. And the concentration of insulin in a portal system is 4 to 5 times higher than peripheral. And that is the reason Allah Almighty has probably fixed pancreas in proximity to liver. So no matter what we do in terms of altering molecules and talk about sophisticated insulins, it will never replicate what Allah Almighty has created. And I mean, obviously, I'm not sure if somebody can make a comment, but I just keep thinking about that ever since I heard that whatever we do, these insulins are flawed. We are treating it wrongly. Thank you.
Thank you. I think.
Okay, now we will move towards.
Diabetes actually. Even with lowering the dose of insulins regular or the rapid acting, still the patients are getting hypers and hypos, and it's very difficult.
Okay.
Do you have, apart from CGM, you have other solutions for that? And what can be the possible reasons, insulin resistance or hypersensitivity to insulin? I fail to understand sometimes how to manage these patients, very difficult sometimes.
So anyone can answer, but if you remember the slide I showed you, there are some periods in life where things go haywire. And, adolescence is one of them. And diabetes can be very difficult to control during that period. And there's so many factors. So you work on all those factors. And of course, one of the indications for the pump is that period of the thing. So you may be able to give them a little space for hyperglycemia rather than make them have too many hypos. But these are difficult areas to work. We all know that these are difficult periods.
Okay, now we will move towards the next talk, use of technology in type 1 diabetes. Does it work better? For this talk, Dr. Syed Abbas Raza will come here. He is the consultant endocrinologist at Shaukat Khana Memorial Hospital, executive member of International Society of Endocrinology, past president of South Asian Federation Endocrine Societies, past president of ACE Pakistan chapter. Sir, over to you.
Thank you. It's wonderful to be speaking after Atif and Dr. Tasnim for laying down the grounds of how and what I'm supposed to say. But thanks for making me comfortable in this position, but I'm not happy for making my life difficult. Because after Atif's motivational speech, the topic that I had was modern technologies and whatnot. So I took out all the slides for the artificial intelligence. If you cannot provide them insulin, I'm not sure if it's worth talking about artificial intelligence working on retinopathy screening and whatnot. So I took those slides off. And again, thank you, Dr. Singh, for going over and showing that map to us at the end, the road. So I'm going to take a step back. I'm going to look at the road which was behind us and road ahead of us. I'm not going to make your life miserable by showing you artificial intelligence is used in diabetes management and again how it should be used, because we are not even at the point. And again, just taking one note from the first speech that we have, I'm very happy and honored that Dr. Jamal is sitting here with us. We took an initiative. If you think of something, it can be done. Last couple of years back, we started a campaign called Run for Healthy Life, in which we activated the younger kids from schools and had them do walking, and we were able to generate enough money so we can fund a diabetes clinic for insulin treatment for a year in Lahore. And Dr. Jamal is doing the same in Karachi as well, because the COVID was a certain place. So again, if there is a will, there is a way. So without further ado, let me start by saying, let's look back at the road that Dr. Tasnim showed us, which was going ahead. But look at that, from 1500 BC, when the initially diagnosis of diabetes was actually documented in the history, you look at in 17th century, you look at diabetes being labeled as something when you pee sugar in the urine. And again, that's when you were initially how you diagnose it. So things are not as bad as that time in Pakistan yet. Imagine yourself in 1776 being hired by your scientists to taste urine to make a diagnosis of diabetes. So thank God we are not the urine this time. Thank God we have developed. So all this half full. I think all of us are here because there's a lot we have achieved, and there's a lot we will achieve in years to come. And I'm very hopeful for people like Dr. Basit and everyone here that will help us. Blood testing came very late. So it took us many 100 years to come to a point that in 1970s, we were able to actually get the glucometer setting ready. It was in 1970s that we were first able to get the A1C in line. And obviously, times have progressed since then. But if you can see, and again, the reason I'm showing you the history, because you cannot know your future if you don't know your history. And I strongly believe in that you need to know your past before you can start deciding what your future would be like. And you can see that the timelines that we are seeing from 1500 BC, there was like hundreds of years before we did anything new at that time. So like our honorable PES executive member was saying that there's a lot that God has provided in a natural way that I think will probably never be able to replicate. But again, we are trying our best to get to the point that where we need to be. I think the revolution and the change in diabetes lingo, if I could call that, is going to change in years to come. Just like we were calling ourselves urine tasters hundreds of years ago to make a diagnosis of diabetes, to a point that you were able to do finger state. Now we are up to the interstitial fluid. And again, we'll talk about what the interstitial fluid, what does it mean for management of diabetes in the years to come. And obviously, without going into the details of what the innovation is, now I think the innovations of even having your saliva being tested for blood glucose will come into play. Even your lacrimal, what to do, and there's some information written there. I don't want to again spend too much time in it. There's a lot of things which are coming in, and luckily for us today, we can safely say that it's not only the future, the past that we can look into. Actually, these technologies are available, and the best thing I can convey to you today is that these technologies are coming cheaper. Just to add to what Atif is saying, there are a lot of people who are jumping into and realizing the fact that we need to do more for type 1 diabetes. Again, there's a lot of activities which are coming out which might help us in years to come. So the question that I always ask is that if you ask a patient with diabetes, and I will just quickly want to have you read through it, what's the first thing in her mind when you see someone with type 1 diabetes? What is she or he thinking? Is it a better A1C control? Is it fasting blood glucose, postprandial, both fasting, or there's something else? How many of us think that it's the A1C and the blood glucose which is in their mind as first? Even when you're talking about the blood glucose, and I will want you to answer it once we get to the end of the talk. What's in our mind? Is that the reality that we're thinking of? Is that something that we're looking at when we're seeing the patient with type 1 diabetes? What's in our mind? Because the problem is that your eyes don't see what your mind doesn't know. So we need to know what the other person is thinking and what they want before we can say that this is the way we want to treat it. So the concept of the patient-centered approach cannot be more utilized, and I repeat, cannot be more utilized other than in a patient with type 1 diabetes, because that's a life-changing event. They're young. You need to adjust to them, not they need to adjust to what you're saying. I was sitting on the chairs next to Umar the other day, and his 2 kids were doing whatever they would want to do. He was adjusting to what they were doing, not they were adjusting to being the chief organizer for Pakistan Endocrine Society event. So he had to. So that's what you'll see in type 1 as well, that you need to adjust to it. Aamir is sitting here, who's been very much part of developing these guidelines. I think no matter what we say, we don't achieve targets. 65%, 69% of us in type 2, type 1 don't achieve the target because it's a multifactorial disease. And again, why don't we achieve it, and what are the limitations? Probably technologies will help us in the A1C, which we all talk about. And again, this is the thing that we always think of, and Dr. Singh very rightly pointed out that A1C is something it should be a glucose-centric approach. And again, because it works. The DCCT trial, which was one of the first mega trials in type 1, showed us that there is no limit for A1C reduction and getting the benefit. The lower the A1C, the better the outcomes are. And that's where we realize that the harder we push on A1C, the better results we get. But we all learn as we go. Then we come to know that although there's no limit of where the A1C would stop and you will stop getting the benefit, the problem is then when it comes down to a certain level, you start experiencing certain things which makes the prognosis or the mortality of these patients higher. It's not that the complications are not having, we are not able to control the blood glucose to a limit that we will need to. And there's a lot of problem with A1C. So what future holds for us is probably changing. Again, I'll say the changing the lingo or the language of how we communicate to our type 1. And this is something which probably is not something we're doing, but this is something we'll be doing. There's a lot of problem with A1C. Anemia in our population is a big problem. The variance of A1C is a lot of problem. Not everyone can get an A1C from a standardized lab in our problem. I have seen A1Cs which range on the same day from 7.6 to 10.2 on the same patient on a different lab. Which lab would I trust? Which variants I will trust? And again, then you need to, so there's a lot to be learned from it. Technologies which were out there were so expensive that I cannot even dream of using them, but these are coming down to a point that we might be able to. The lower you push down your A1C, the more complications you start seeing, hypoglycemia. And that's the reason, then in ACCORD and other trials, we saw that if you bring down your A1C, there was more mortality in some few people because the number of medication, the type of medication that we were using were probably wrong. And the effort that we had to make sure that your blood sugar is low was a little too much for comfort. The new lingo, and again, this is for all of us to learn. Probably it's not going to be A1C. It will be also hypoglycemia. How much hyperglycemia, and I'll tell you what I mean with it, and what the time in range, and probably diabetic ketoacidosis. So the art of balancing blood glucose in diabetes is going to be a major change in how we treat, not just the simple number. So number would always be there, but how we are achieving it and how we are going to get to that is something. It's the balance between getting to the goals without getting into trouble. So this is, I think, the message which all of us should know when we're treating type 1 or type 2 is getting to the goal without getting into trouble of getting all these complications. So the two concepts that I would want to say, and again, this is based on the fact that this is something we should all be looking at. First is glycemic variation. What does glycemic variation? I have people who pretty much know inside out of this variability, but again, for the sake of everyone, let me show you two patients with A1C, which is 7.8, and one person has a blood glucose which ranges like this, and the other person blood sugar ranges like that. Both of them have the same A1C, but look at the variance in the blood glycemic control. The reason I say this is we always say there are people who get into trouble and there are people who don't get into trouble. How can we know, looking at the A1C, if A is better off and B is better, or B is better? Because both of them, we are checking the blood glucose probably at this time, which both of them are same, but we somehow miss out on these things. So this is where the new technologies will be able to help us out. Where does it lead us as far as management of diabetes is concerned? Are there any outcomes? And I want you to spend some time here a little bit. These are the individuals who actually don't have blood glucose, but if you look at variability and the mortality, and again, I'm usually totally against presenting very complex studies during talk because the attention span is less, but I want you to focus on just one thing, that even if your blood glucose is 99 or less and your variability is high, which is in red, versus if your blood glucose is more than 180 and your variability is less, the mortality is actually less in it. So if you're in ICU and your blood sugar is going up and down, that's actually a sign of your body telling you that there's something wrong that is going on, and that increases the high mortality. And that is not true only in this. It has been shown that it has tendency to cause more hypoglycemia, more cardiovascular if you have more variability. Something traditionally we haven't been able to monitor, something traditionally we haven't been able to judge. Now we can. And again, we'll talk about it briefly as well. Time in range is just another way of looking at it, and I'll show you what do I mean by that. So if you look at time in range, it is the time that you spend when your blood glucose is normal. So it's in the green zone. A time in range is what a normal individual will spend time till he develops diabetes. So the green zone is the time when you're looking at it. So if you look at person A and person B, both of them have the same A1C. But look at the time, even if you discount the hypo and hyper, but look at the time that this A is spending not in range, and while the time is spent by time B in range. So this time in range also sometimes helps us decide if we, and again, if you look at it, the most important factor for someone with type 1 is that time that the person spends in his day's life. Reason is, when he's hypo, he's not feeling well. If he's hyper, he's not feeling well. So what is most important for a kid with a type 1 is to feel better in the time when his blood glucose is time. And that's where the concept of the whole everything. Are there any benefits? Amazing results as far as time doesn't. The frequency of retinopathy and frequency of microbleeding. If you're spending 70% or more when you're in the green zone, versus if you're spending less than 10, look at the complication rate, which are different. So just think for a second, were we missing our point when we talked about the glycated A1C only when we talked about the complication? And think about when we were seeing a patient with type 1 and thinking, do both of them have the same A1C? Why one getting the, apart from the genetic predisposition, maybe we were missing something which was important. So obviously, there's the change and the history that I showed earlier. For the reason is that the history of from the urine to the blood to the CGM to the institutional has developed, and I think the groundbreaking technology for making sure that we are not able to measure these changes is the continuous glucose monitoring, and this is how you monitor it. Traditionally, there were CGMs which were expensive, they were required. Technology has moved on actually. Now you can even have again, in the next couple of years, you'll have a contact lens which will record your blood glucose. You don't have to even put a patch around your. So these technologies will help you develop all these variability. You have novel insulins. The concept, and again, I would second what Dr. Tasnim said was, I think the management of diabetes, I wish and I hope that everyone and anyone in Pakistan, in the world, would get the same treatment. But the ground reality is not true. Probably we need to modify our treatment based on what we are seeing. So it's almost, and I said that earlier too, that with the newer novel insulins, if someone can afford it, you can achieve those goals. So if you're not giving the opportunity for that person to control blood glucose to an ideal way, I think you're doing injustice to that patient who can afford. If someone who's not affording the insulin and he's not able to use those, and we shouldn't be prescribing those, and then the question arises, which we had a debate on, which insulin to use, how to use it, and the best possible. The CGMs are the way forward as far as, and this is generally how you would look at. You'll get the person's reading on what the blood glucose has been within normal. It's beautiful. I don't know how many of you have seen CGMs or the continuous glucose monitoring. Thank you. So again, the reading, if you look at it, it's beautiful. You look at it when the person was having hypo, honestly, you look at the A1C, it's perfectly fine, but you see that every day at 2 a.m. he's getting hypoglycemic. So these numbers look wonderful, and there's wonderful ways that you can think. We talked briefly about the pump diet. I'm not going to spend too much time in the interest we are already getting late. The insulin therapy, do you know what this is? The first pump, thank you. We have evolved since then. Again, today you can wear a small pump next to you, which will not only record, which will also sense and do everything. Probably you can get away with, right now the indication for pump is type 1, if you have brittle diabetes, which I think someone mentioned here. So all these things are an indication. But if you are a type 1 and you want to wear a pump, I think probably that's the best thing you can do to yourself. But again, there are other modalities you can use if you cannot afford the expense of one. Artificial pancreas is a reality. I think, again, we have come a long way as far as artificial. I'm not going to again spend too much time, because this is something that we started off with something like this, which probably no one could wear, to something like, which is again like a pump, in which you'll have it working like a pancreas. So the question is, and then the last two slides before I finish, is what does patient in mind? Is actually the best glycemic control, the time in range the patient is having, and how the person feels. He doesn't relate to the A1C. He doesn't relate to your hyperglycemia or hypoglycemia. He only relates to the sugar reading or the fluctuation that you can. So the question is, actually, this is not something which is in the mind of the patient with type 1. It's all about balancing act. On one side, it's a glycemic control. On the other side is the hypoglycemia, time in range. And we sometimes miss the boat focusing either on one or the other or the third one. The art of living and treating type 1 diabetes is that balancing act, that we shouldn't go this or that way, but we should be balancing it out. And this was the best I could do as far as graphics are concerned. Thank you very much.
It's over to chairs if the questions are allowed. We are short of time. Okay. One question is allowed. Any question?
Thank you, Dr. Abbas. It was a nice lecture, you know. Actually, my comment on the control of good diabetes control, blood glucose control, it is not only the, the type of insulin, I mean, the insulin does play a part, than the regimen we are using, but the patient education and the family support is also very, very important in the cases of children. And, unless that is there, we cannot achieve the targets also. And sometimes there are social problems. There are parent separation and other things. And, we have seen that these kind of issues. So I think that good blood glucose control is not only the use of appropriate insulin and other measures, but also the patient's education and the family support is very, very important.
100% agree. This is one of the, Dr. Javed Akram, I don't know if you're raising it. I would love to hear the comment from you as well. From one of the only diseases, and Dr. Jamal, you can help me in deciding that. The only disease that I see, because I do see type 1, when the patient is sitting on the couch comfortable and the mother and father are crying, is type 1 diabetes. On all diseases, the patient is crying and other ones, kuch nahi hota, kuch nahi hota. And actually, this is the only disease, the patient is eating something or he's just having fun and the mother and father are crying, and it's difficult to treat the mother and father before I could start treating the diabetes. And again, very rightly pointed out by Atif, and again, it's actually a stigma, and I second you on that. Thank you.
You did wonderfully well explaining everything. My just a comment is that we are all doing CGMs by either Meditronics or with Abbott Libre. I think it's also important to educate the patient that this is interstitial fluid blood sugar, because many a time they do capillary blood sugar, or sometimes they get venous blood sugar from a lab for whatever, and there is a wide variation, and then they give up on using these devices. Then they go in disrepute, because it's important, I think, also for the companies and for us to stress to them that this is an interstitial fluid which will differ from the venous blood and the capillary blood to a significant. But I think what we also need to do, maybe a study together at some stage. We have been co-author in many studies to see time and range. When you are talking of time and range, I presume you are talking of mostly the interstitial fluid. How does that correlate with the capillary if we do that? I think especially in the Pakistani population, because we are very, very different from Caucasian and so on. So the local data will be very, very interesting with the CGM, with the interstitial fluid, and correlating them with the complications.
Couldn't give me a better talking point or a practical point. It's an interstitial fluid which lags at least half an hour with the blood glucose. So you cannot exactly tell. So if you're feeling hypoglycemia and the CGM is telling you that it's not that low, probably it's lagging behind. And we need to probably our skin thickness is different, our fat content is different, or maybe we don't have a local data as far as CGM versus glucose monitor, because it's been standardized internationally, but I'm not sure if we have the local data on it. So it'd be an honor working with you in that project.
Sir, Assalamu alaikum, sir. Thank you, Abbas. I think we finished the question and answer. Please, that's the final comment, and because the hierarchy of PES is here and Diabetic Association and corporate sector, just to let you know that we are now working with the ministry and through MCOC, trying to develop our own CGMs and glucometers in Pakistan. Anybody who wish to work with it from scientific or clinical or research or study point of view or support or finances are most welcome to contact us. Thank you.
Now our next speaker is Professor Jamal Raza for the talk on type 1 diabetes in children. Over to you, sir.
Assalamu alaikum. Thank you. It's an honor and a pleasure always to come back to PES, remembering the small room that we started with 8 to 10 people. Fortunately, quite a few of them are still here, including myself. I don't know how long that's going to last, but as long as it lasts, I'm enjoying it. So, what to say? Sorry, thank you. Okay. So a lot has been said already. So made my job easier with Abbas and Atif and Dr. Tasnim's presentation. I'll try and be quick about it. We have gone through the numbers a lot, and we've been debating, but this is what we have: a prevalence of more than 1.1 million currently of under 19. This is last year's data, and Pakistan is low on the colored map, but we've all discussed that probably these numbers need to be corrected, and Basit and I are hoping that we will do the prevalence study to make this happen. This was published this last week on Lancet with Professor Bhutta and his team, and this is interesting because it shows that the trend it's not just the numbers that are rising, the trends in different regions are different, and I don't know whether you can see the yellow line over there, but that's the South Asian line, and that seems to increase in numbers, both in terms of the incidence and prevalence. So we have some evidence that we have this on the rise. The other graph on the top actually is even worse, because that's telling you the Delhi's, and that is the disability adjusted life score, and that tells you that there's a great variation between the Delhi's when it happens in the Europe and the other areas, and then when it happens in countries like Pakistan and the other lower middle income group. So let's do the technological takeoff, and we'll do a crash landing and see where we are. And I think we are kind of repeating ourselves, but it's interesting because we as independent speakers have coming pretty much to the same conclusion. But let's look at the celebration that's been going on this year and the timeline that we have on the various types of insulin, and we have come a long way from 1921 to 2020, where we have this once weekly basal insulin, and of course we have the analogs and the fancier insulin somewhere in between. So this is where we are, and this is quite an achievement. There's nothing taking away from the various types of insulin and advancement on the scientific ground that has happened, and it has given patients benefit in the wider picture, of course. I will talk about the second generation basal insulin because I'm looking at the pediatric aspect as to what is allowed as a pediatrician to be utilized. And this again came out this month, telling about the head-to-head comparison between the glargine 300 with the Ryzodeg. And pretty much as expected, this is showing an equal result, slightly better with glargine 300. And when you shift them from the first generation basal insulin to one of the second generation, again, we see a moderate improvement in the A1C. This is the RESTORE-1 study. The other mode of insulin, Dr. Tasnim has touched upon. We have been talking about the inhaled insulin for a long time, and it has come around, but it hasn't stuck, or it hasn't delivered us the promise. We still have one or two available, but there is some new technology that has been used, vibrating mesh, and hopefully we will have a slightly better inhaled insulin in the coming years. Another hubris is the oral insulin. I remember taking my talks 20 years ago and got very excited when I mentioned the Ora Med and Oral Lynch. और ये वो सवाल है जो हर मरीज हमसे हर दफा करता है जब डायग्नोसिस होती है कि डॉक्टर साहब कोई गोली दे दें बच्चे को इंजेक्शन कैसे लगाएं and this is the pain that you were talking about when the parents are crying and the child is playing. It's really painful for your child to be diagnosed as type 1 diabetes and you are looking at 4 injections a day and 4 or 6 testings every day. But this is where we are. Still, we are, it's more of a hubris than a reality. But there's an interesting newer thing that I just looked up, and this is the use of the oral insulin in prevention. And they say that if you use the oral insulin from 3 to 6 months in children who have been at high risk for developing diabetes, you can actually delay the diabetes very significantly. So we need to all read this up a little bit more and wait for the results, but this is a global platform for the prevention of autoimmune diabetes. Already mentioned by Dr. Tasnim, because since we were on the prevention, I just thought that we would just briefly mention that this is where we are with Tiplubazib, and the long-term follow-up is showing some promise. But again, we have gone through this road before, and a lot of drugs that have shown earlier promises in prevention have not turned out to be the really the magic drug that they said. Made my job easy. Thanks, Abbas, for the CGM. We know that CGM this has been a major really difference, I think, and looking at the meta-analysis, both in the pediatric and the adult population, we see that there is a clear improvement. And this is the meta-analysis that looked at the different trials, and the conclusion was the CGM as compared to the self-monitoring blood glucose clearly show reduction in the A1C and severe hypoglycemia. And another trial which also looked at the same thing, but in a slightly different way as what you were mentioning at the time and range, time below range and time above range, and the glucose variability. And on all accounts, the children and adults who were treated with, they were managed with CGM have shown an improvement. So this is something that has really, what you have just said, changed the monitoring concept of the diabetes and HbA1c that we have been looking at, as now probably in the years to come will be substituted by the time and range in the slide that was shown by Dr. Tasnim as the freestyle library, which is not now available over here and kind of becoming a little affordable as compared to previously. So I think we are good at this. And this is what we are targeting. So if we are targeting more than 70% in time and range, then we are good. Anything on the higher side, more than 25 is bad. Anything on the lower side, more than 4% is bad. And this is the result actually, speaking for itself very prominently, that every 10% increase in time spent in time and range will reduce the risk of microalbuminuria about 40% and retinopathy by about 64%. So that's a very strong data that is coming up. And of course, the limitation is that you can only look at the time and range for people who are using the CGMs. That's besides the point. Looking at the pumps, actually, I was looking at the different registries, and the Sweet registry, the US registry, they're very variable numbers ranging from 0% to 90%. And even in the US registry, where the numbers are 68% of use in pumps, there are great differences between the various ethnic groups and all. And same with the European studies, and wide variability between the England and the Wales numbers. You can see 14% versus 41%. Patch pumps is also something that is very exciting, and I can see a number of patch pumps being developed, which are tubeless, which have got an infusion set inside, and they should give you much more freedom in the movement and utility compared to the traditional pump that is available. These are the number of patch pumps that have been in process, and various trials have been going on, but a little less literature is coming in patch pumps than on automated insulin delivery, the AIDs. Various stages of AIDs that have been now mentioned. The first one shuts off during hypoglycemia, and then they could predict hypoglycemia, automatically adjust the basal insulin, give correction boluses, and take the meal and give boluses accordingly. The MiniMed has been around in the US for some time. The 670, which adjusts the basal insulin every 5 minutes. The T-Slim X2 pump used with the Dexcom technology is also coming up in a big way. And this is the data for the use of the T2 Slim pump. And the time in range spent was 78% versus 79 and 79% in both T1 and T2 used in the pediatric population. And this is the sustainability of the pump after 6 months, and you can see that the time in range is still maintained after 6 months of the use of the pump. Omnipod is one of the patch pumps that has now been used with various technologies and good adjustable targets. And this is the data in the efficacy of Omnipod, where you can see it was used in 96 hours study, and the results were pretty good with the use of the pump. This was used both in children and adults. Again, some data on the use of the Omnipod showing good results. This is the latest on the block, the new MiniMed 780, which is about to come, which is a significant upgrade in terms of the artificial intelligence and brings down the adjustable glucose target down to about 100 milligram. And this is the use in children. This is recently presented in the ISPAD meeting. And if you can see that less than 15 years and more than 15 years, the time in range was pretty good. It was acceptable, more than 70% as anticipated. One of the newer artificial pancreas that is going to be in the market, probably not too far away, is from the Beta Bionic islet system, which is a revolutionary bionic pancreas. It has the inbuilt system of delivering insulin and glucagon. So sometimes there's a bihormonal bionic pancreas, which is using both insulin and glucagon. And currently the trial is going on. The results are, they have completed the trial in October this year, and the results are going to be out in early next year. Tight pool loop is something that has been set up as a separate, it's a non-profit organization which has set up an algorithm independently of the user pump. So they are not bound to the pump that they are using or the CGM, and they are using this technology for the benefits for the use of different pumps. And then the new thing is the beta cell regeneration. Islet cell transplantation has been around, but newer pluripotent stem cell technology is paving the way for developing the beta cell regeneration, which probably is the cure that we are looking for a long time. Dr. Sahab, कोई ऐसी चीज नहीं है जिससे ये बीमारी ठीक हो जाए, तो शायद ये अगर कहीं हम इस पे कहीं पहुंच सके तो maybe this is the answer, but of course there are many a slip between the cup and the lip. So what's the situation on the ground? Landing gears. This is another timeline. This is interesting. This is again published this month in Lancet. If you look at till 1961, the period of relative stability for the insulin pricing, and then we go beyond 1961, 70s and up to 2021, and we have the synthetic insulin, we have the designer insulin, we have the CGMs in the artificial pancreas, and that has clearly pushed the price for insulin to become affordable or not become affordable for a great majority of children who are in need of this treatment. And again, one of the important slides from the same presentation, we are talking about pre-insulin eras and a lot of children dying when there were no insulin. Look at this data, which is looking at the lower middle income country groups and some of the African, and we are, after 100 years of insulin, we are still not far away from where we were 100 years ago in terms of their life expectancy is concerned. So that's really an eye-opener. That's really where we should be looking at, because this, I believe, is the key word here, the equity that we need to establish. I've never met Dr. Jamal. I think he was here. Sorry, आपकी इजाज़त के बगैर मैंने आपका blog लगा दिया है, but I really like that. So this was important because it says one of the major barriers to the insulin access for the majority of people living with diabetes is the relentless drive to replace the human insulin with analog insulin, which on evidential basis add little value over the glycemic controls. 3 companies are controlling the whole thing of the insulin delivery. So are we, as the healthcare professional, part of the problem, then part of the solution? So there are a lot of thought-provoking things in there, which I would like you to leave with. Sorry, ये आतिफ की मैंने बच्चे की तस्वीर भी लगा दी, इसमें वो आतिफ ने भी डाली थी, जो child who is not getting insulin. So this is where we are in terms of the ground reality. When analogs came in, these were the actual words that the companies told us. Dr. Saab, आप Mercedes को Mehran से कैसे compare करेंगे? So, is this really Mehran versus Mercedes? This is, the trials meta-analysis, and this is the conclusion that we have very little to choose when it comes to the final results in the analogs versus, and the price is 3 times, it's not less, maybe more. We have also set up a SPED registry, and I'm glad Basit has now come up with the national registry, and we'll see how we can collaborate with that. And this is the NICH data, SPED is the Society of Pediatric Endocrinology and Diabetes that we have established. And this is the NICH data that we have got in the last few years, over nearly 1,000 kids in this registry from different age groups. This is where we are, despite all the advancement that we were talking about back in the earlier slides. This is the ground reality, and 60% of our children are still on the basal bolus regime. We are trying to move on to the multiple dose, knowing the benefits, of course, but there are limitations, and this is the ground reality that we need to talk about. Presentation की हमने बात की, awareness की. Atif has had a very emotional presentation about the awareness. This is my slide from back in 2002 and back in 2006, and we were talking about a DKA prevalence of 53 and 54%. This is the data from the same institute 2020, and we are still in the range of 50%, and this is the registry data, and 519 of the 900 something has presented with DKA. So we are really far off from the general awareness, and the video you were developed is fantastic, and we need to do much more effort than this. I really love this poster when I saw this in the European thing. Very simple, gives you the message: any child who is frequently peeing and has an unquenchable thirst can have diabetes. Please be aware of that. And that's a simple message that we want to put across. Because I've not shown you the numbers here, but when I see patients in my private clinics, the data, the incidence of DKA is very different. It is somewhere around 10% or less. So it's the underprivileged or the masses which need to be conveyed. So maybe we need more than the video, social media. We need printed things, posters, and various ways then the message can be reached. This is another question. We looked at our autoantibody data, and this is in about 520 children. We did 3 antibodies, the anti-GAD antibodies, the islet antibodies, and the other antibodies. We haven't done ZN8. But this is a little worrying. 35% of our kids were negative for all the 3 antibodies. Is that true? Is that really something that we are missing out? So we need to know our own what's happening in the backyard. We have, this is the recently published data in the monogenic diabetes that we have done, and about over 1,000 patients we have sent, 39, and 27 had neonatal diabetes and 12 had extra pancreatic symptoms. And this is the result that we have got, that in children less than 9 months, 18 out of 27 were positive for monogenic diabetes, and we have Walcott-Relison, PND, permanent neutral diabetes with KCNJ111 mutation, ABCC8 mutation, GCK, and the other mutations. And all of our older children were positive for the various types of monogenic diabetes. These are the different mechanism of the genes acting on different levels. Mohsena, I think, is going to talk about, Dr. Mohsena will in the separate session about the different types of Walcott-Relison. So I'll skip these slides a little bit. Thymine responsive Dense syndrome. We have got very interesting 2 mutations. And the same family, one child was treated as type 1 for a long time until the newborn had diabetes, and we sent the genetic samples, found that this is ABCC8, put them on sulfonylureas, and they are both off insulin. And there are many patients like that. So we need to be aware of the ones that do not need insulin. They are few in numbers, but they are still there. H syndrome, glucokinase mutation. So this is where I want to come back, and perhaps with all the fancy insulins, with all the designer thing, this is where we need to concentrate back on education. And we must realize that the differences in the level of the education that needs to be conducted to the parents, because it's a completely different story when you are talking about an infant and toddler. We are totally dependent on the parents or the care providers. Recognition of the hypoglycemia is more common and more severe. Is when we talk about school-age children, the mechanism is, sorry, the onus is completely different. The priorities change. We need to learn about, need to involve the children of learning about their hypoglycemia symptoms, adapting diabetes to their school program if there are any, but it's a different skill, teaching the teachers perhaps for the awareness. A lot of schools are still refusing kids to be admitted to the school, and then of course comes the adolescents, and as it is, adolescents have their own challenges, which are greatly compounded when you have something like diabetes, and the teenager sometimes can just refuse to take treatment, and this is the psychological issues study that was done at NICH, and 17% of the patient had really depressive illness, which will greatly affect their diabetes control. So the goals when you are treating children are probably in our own backyard is probably different, and we need to set up realistic goal for each child, the family, the age, the background, etc., etc. We need to target the near normalization of the glucose and the A1Cs and now the TIRs, and whenever possible, we need to prevent decay, make sure that at least decay doesn't happen, prevent severe hypoglycemia. We need to assure a near normal quality of life as much as possible within the constraint of the whatever situation we have, maintain a normal growth, provide a multidisciplinary approach, which has already been mentioned, a close surveillance on the complication. So this is the conclusion, and if we conclude, then I would say equity of care should be the prime focus of all the major players and the stakeholder we have. I'm glad we have many in this room who can join hand and make sure that at least some kind of equity is provided to all patients, irrespective of their social and educational background. We need to improve the mass awareness, as already mentioned. We need to identify the backyard, in our own backyard, diabetes type. Are we picking up all the monogenic diabetes? We need to make sure, and therefore we need to have a more tailored, holistic approach rather than just providing them with insulin and trying to target their A1C. Thank you very much.
Excellent talk as always, Jamal. We can have 1 or 2 questions. Jamal Sheikh.
Dr. Jamal, Mike.
We know we are running short of time, but yeah, 1 or 2 questions.
Thank you very much,
please.
Professor Jamal Raza, for updating on topic of type 1 diabetes management. There is some mention of some vaccines for prevention of type 1 diabetes, like vaccine against Coxsackie B virus, which is most notorious for causing this genetic alteration, or even BCG.
Yes.
They are done on mainly Finland, because Finland has got more population of type 1 diabetes. Can you give some update?
I mean, there have been theories about, especially about BCG and the prevention of type 1, but these vaccines issue are not really haven't gone very far. We already have BCG vaccination available for all of our kids. So there isn't really robust data that can suggest the clear evidence for protection or some kind of protection for the type 1s. We know the genetic basis will give them protection and certain genetic basis will make them susceptible. And the whole process starts off with a trigger with autoimmune mechanism, but really haven't got the vaccine that will clearly show that the incidence goes down.
सर मोनोजाइटिक ट्विंस होते हैं सर, उसकी प्रिवेंशन हम कैसे करेंगे जब आगे जाके वो टाइप 1 डायबिटीज बनेंगे या टाइप 2 बनेंगे? मोनोजाइटिक प्रिवेंशन उसकी कैसे करेंगे वो डायबिटिक ना बने? Monozytic twins.
Not all monozygotic will develop diabetes. It's only 50% will develop diabetes. So you have the genetic predisposition, which will not necessarily go on to develop. We are talking about the type 2 diabetes, the autoimmune diabetes, not the monogenic diabetes. Monogenic diabetes, of course, will have autosomal recessive or autosomal dominant transmission. And if you are able to identify the gene, then you are able to offer the treatment pertaining to that particular monogenic variety of diabetes. But monozygotes will not go on to develop diabetes, all of them.
सर दूसरा आपने जिक्र किया है स्कूल का सर, इंग्लैंड के अंदर जैसे टाइप 1 डायबिटीज के स्कूल अलग हैं पेशेंट के जो है, हमारे पाकिस्तान में अभी तक इतनी अवेयरनेस नहीं दी।
नहीं, I'm sorry, ये तो बिल्कुल नहीं, होना भी नहीं चाहिए। मुझे पता नहीं इंग्लैंड में अभी अलग है या नहीं है, लेकिन अगर है भी तो होना नहीं चाहिए, because you don't want them to be stigmatized. That's the whole idea. हम तो उनसे कहते हैं कि आप उसकी डाइट भी अलग ना करें. The whole family should eat the same diet so that the child does not feel stigmatized. अगर आपने उस पे स्टिग्मा लगा दिया कि ये तो टाइप 1 है, ये तो अलग हो गया भाई, छूत की बीमारी है. No, please don't do that. Thank you.
Dr. Jamal, you were talking about the cost of insulin.
जी sir.
We have been always being dominated on our head by 2 companies which are producing, and they can increase the price whenever they want at will. Now, the price of 70/30 vial is something about 1100 rupees. Local company, the GETS, which is there on the board, is producing that same thing for 600 something. So the cost is a big difference. Let us be aware of this thing.
Certainly, sir, we will. That is what I was mentioning when we talk about the equity and the type of insulin. So we've been lured into this belief that the analogs are fantastic. They are better, but they're not probably fantastic. So it's probably not one size fits all solution. You can use whatever the best you have or can afford or can use. But at the same time, you should not be deterred from not being able to use the analogs. And as mentioned by Dr. Tasnim, the DCCT trial never used analogs. So, even with a regular human insulin, you can do all the good wonders. So it's all a question of maintaining a normality, a near normal situation, rather than the type of insulin.
Thank you, Jamal. Thank you once again.
Yes, sir. Now we are moving towards the last talk of the session. This is the talk about RYZE with Ryzodeg initiation and switch effectiveness study. This talk will be delivered by Professor A.H. Aamir. He is the renowned endocrinologist and head of the Diabetes and Endocrinology Unit at Hayatabad Medical Complex, Peshawar. He is the Vice President of South Asian Federation Endocrine Societies and past President of Pakistan Endocrine Society and past President of ACE. And from University of Sydney, Australia, the foreign speaker will join us, and he is Professor Gregory.
Well, hello, ladies and gentlemen, and welcome to this important session. I'm here today to talk to you about the RYZE study. What does that stand for? A Ryzodeg initiation and switch effectiveness study. This is a multi-center, prospective, non-interventional study which is looking at the clinical effectiveness of Ryzodeg in patients with type 2 diabetes in a real-world setting. So what do we really mean by that? Well, we're used to clinical trials. We're used to reading those results in the many journals. They're usually well controlled, they're strictly enforced. It's a fairly homogeneous population that they study. There's often limited numbers of patients. The patients that they recruit are motivated to participate in the study for a period of time. So compliance is often very good, and there is some limited comorbidities. In addition, the investigators who are running this trial are generally highly experienced and trained, and there's regular follow-up, and maybe that means that not always the results of clinical trials are translatable to the real world. So on the other side of the coin, a real world study is everyday clinical practice. There's a broader heterogeneous population, often larger number of patients. The compliance may just be up to the sort of patients that you're seeing in the clinic. They'll have lots of other comorbidities that mightn't have allowed them to get into a clinical trial. There are the usual providers of care. So it's the people who are providing care day to day that are important, and follow-up is according to local clinical practice. So this study was conducted in 6 countries around the world. I want you to pay particular attention to the results from India and Saudi Arabia, but also the Philippines, Malaysia, and Australia also participated in this trial. And this was a trial in which the doctors had already made the decision to commence a patient on Ryzodeg. And we're going to look at the results of that on hemoglobin A1C, a number of secondary endpoints, not all of which I'm going to have time to present to you today. And also I'm going to touch a little bit on resource utilization. So what happened in this study, as I mentioned, was that the clinician had already made the decision to start the patient on Ryzodeg. And once that decision had been made, the clinician had to ask the patient, would they be happy to have their data collected over a period of time of the study? And the follow-up was 6 months. So the first visit that occurred after 6 months entry into the study was considered to be the end of treatment for the study. So 1,462 patients invited to participate, 1,122 provided informed consent. Out of those, 1,102 were commenced on Ryzodeg, and 1,015 actually completed the study. So overall, that was 92.1% of patients who completed the study. So here they were, patients with type 2 diabetes and commenced on Ryzodeg as per local practice. And as I mentioned, the end of the study was around 6 months, but the first visit that occurred after 26 weeks. There could be any number of visits in that follow-up. So that was up to the clinician. So this was non-interventional, it was multi-center, it was prospective in terms of the data gathering, and as I mentioned, the frequency of visits was according to local practice. Patients were over the age of 18, and Australia, India, Malaysia, the Philippines, Saudi, and also South Africa were the countries that participated. So just a very broad overview of the population we're looking at. Mean age was 58 years. There were slightly more men than women who participated. The patients were overweight, and the hemoglobin A1C at entry was 9.8%. Now, what therapies did the patients come from? Well, about 30% came from previous oral hypoglycemic agents. This is overall. We won't talk about the Australian data, just the global data. So over 30% came from orals only. And the 2/3 of the patients, or 60% of the patients actually came from other insulin regimens. 30.6% from a basal-only regimen, 7.6% from basal bolus, and 22% came from pre-mixed insulin. So taking all of the patients together, most of the patients came from regimens with which the clinician was not satisfied, and around about 10% came from GLP-1 receptor agonists. Why did they decide to put the patients on Ryzodeg? Well, the commonest reason was to get better glucose control. It was believed that this formulation would allow that to happen. And I should mention, you could pick more than one of these reasons. So there might have been several reasons for the choice, because the drug lowered the risk of hypoglycemia. There was flexibility in the dosing regimen because of the pharmacokinetics of the insulin. fewer basal injections or fewer injections than with basal bolus therapy, and some other features like you didn't need to reconstitute the insulin as you did with a pre-mixed formulation. So these are all the different countries that participated, and these were the baseline hemoglobin A1C levels. So this doesn't say anything about how good each of the countries were in controlling diabetes. This was simply at which level of hemoglobin A1C the patients in these various countries were asked to switch to Ryzodeg. So overall, 9.7% was the value. In Australia, Ryzodeg was being initiated at a lower starting A1C, 9%. In India, 9.8%. And in Saudi Arabia, 10.1%. And the other countries are shown there. If you have a look at the change in hemoglobin A1C by country, you can see that there were some differences again across each of the different countries. But if you quickly do the mathematics, you'll see that roughly the different countries in that 6-month period of time ended up at just over 8.2%. So India that started at 9.8 got down to 8.2. Australia that started at 9 also got down to 8.2. So in 6 months, under usual practice, that was the sort of glycemic control that could be anticipated. Now, you could argue if things were done differently, maybe you could have done better than that, but this is just the way in which the trial was run or the data was gathered. And it might have been concern on the part of the investigators if they were going to get a lot better control, maybe dropping the hemoglobin A1C very rapidly wasn't a good thing to do. Could that exacerbate retinopathy, for example? If we look at it based on the treatment group that the patients came from, it may not be surprising that the highest hemoglobin A1C was in patients taking who came from an oral hypoglycemic regimen. And again, 10.2% dropped down to about 8.2% after 6 months. And you can see again the changes that occurred based on the different therapies. If we want to ask now, well, what did the clinicians do in terms of dosing? Did they start with once-a-day Ryzodeg? Did they start with twice-a-day Ryzodeg? And what you can see from this slide, it very much depends on the insulin regimen or the regimen that patients came from. So, for example, a patient coming from a pre-mixed insulin background was more likely to start on twice-daily insulin because that was probably, for most of them, what they were on before. If they were on a multiple daily injection regimen, 2/3 of them started on twice daily versus once daily. But actually, if you looked at patients who were just on oral agents or who were on just on basal insulin, the clinician was more likely to think that a single dose was a good transition for those period of time. And during the study, I should mention that only about 9% of patients switched from once a day to twice a day. So in that 6-month period, the clinicians were prepared to continue with the dosing regimen that they had started the patient on. Now, if we look at the starting dose of Ryzodeg, there was a difference between the dose that was chosen for patients going on once a day versus twice a day, 24 units, and then almost twice as much for patients starting on twice a day. If we then compare the previous dose of insulin that the patients had been taking, so this is obviously just the insulin users, you can see that the premixed insulin users were on average taking 48 units a day. The basal bolus insulin taking patients were taking 32 units a day, and the basal onlys were taking about 28. Whereas if we look at the patients who went on to twice daily regimen, their starting Ryzodeg dose was 48, and they came from basal units, 32 units only, basal bolus from 41, and from premixed users coming from around 60 units a day. That just gives you a bit of an idea about how clinicians on average move patients from different insulin regimens in terms of dosing and how that varied according to the frequency of initiation of Ryzodeg. What happened overall with the doses of insulin that we used? And this varies very much depending on the previous insulin regimen. And I haven't got that data to show to you today, but have a look here overall. If you take the total population of people who were taking insulin beforehand, overall, there was a little decrease in the basal component of Ryzodeg in the follow-up period, but there was a little increase in the prandial component of 1.8 units. And if you therefore can take those together, overall, the dose of insulin roughly stayed the same, or if anything, was very slightly less, indicating that for the total population, these changes weren't achieved by giving much, much bigger doses than on average this population was taking before. I do make the point, however, that when the data is finally released around different insulin regimens, you might find that these figures are a little bit different. Now, what about hypoglycemic events? Hypoglycemia was the events that were reported by the patient. So they started off reporting the events they had in the 4 weeks prior to initiation of Ryzodeg, and they then reported on the events in the 4 weeks prior to the end of the study. So let's start off with non-severe hypoglycemic episodes. So observed within 4 weeks, 128 patients experienced 364 events. By the time the study had come to an end, only 44 patients were now experiencing events, and they experienced 162 events. And there's the p-value for the rate ratio, the rate of hypos before compared to the rate of hypos afterwards. Highly significant difference. If you look at non-severe nocturnal hypoglycemic events, so a fraction of these, 59 patients were experiencing 142 events. By the end of the study, 14 patients were experiencing 31 events, highly significant improvement. Severe hypos, not so many of those, and that's what you'd expect. At the start of the study, 23 patients had 51 events. By the end of the study, only 3 patients, but they had 3 events. And if we have a look now at the change in hypoglycemia by virtue of what was the previous therapy that patients came from. So severe hypoglycemia based on therapy, none of these patients had events, in the oral patients only. Non-severe hypoglycemia in the oral patients, significant risk reduction, 76%. The basal taking patients, 76%. Premixed patients, 72% reduction. No difference in the MDIs and no difference in the GLP-1s. Nocturnal, non-severe hypoglycemia, no difference in the orals now, a very big difference in patients taking basal insulin, a significant difference in patients taking premixed insulin, and no difference for MDIs or GLP-1 analogues. So when we look overall by previous treatment group, not all of the groups specifically had a reduction in hypoglycemia, but significant numbers of the insulin-taking patients, particularly basal only and premixed, did get a significant improvement in at least 2 of the classes of hypoglycemia. Severe hypoglycemia, I should have mentioned, but it is a standard definition, was where the person needed some assistance of an external person to provide carbohydrate or give glucagon or do something to correct the hypoglycemia that the patient couldn't correct themselves. If we look at, was it always the patients taking twice daily insulin where the improvement of hypoglycemia didn't occur or did occur? No. If you were prescribed once a day, you had a significant reduction in non-severe hypoglycemia. And in fact, if you were prescribed twice a day, numerically, you were getting even a greater apparent reduction in hypoglycemia. Nocturnal non-severe, again, same thing. Whether it was once or twice daily, the improvement of hypoglycemia was there. So overall improvement of different types of hypoglycemia, some differences in the grouping depending on what treatment the patient came from, and overall improvement, whether there was once or twice daily administration, but actually there was no severe hypoglycemia in the twice daily group. Now, what about the expense of achieving these great results? Was the payoff for that an increase in body weight? Well, actually, no, it wasn't. And this is a very interesting, and you might want to think about why this occurred. Overall, there was a 1 kilo reduction in weight in patients who, during the treatment period, this occurred in patients coming from oral agents or from basal only or basal bolus. If you look at the premixed group, roughly no change. And if you're looking at the GLP-1s, roughly no change. But overall, weight seemed to be better in patients coming from basal bolus therapy, basal alone, and oral agents compared to baseline therapy. What about resource utilisation? Well, this one's very interesting, and we're just teasing out these results a bit more. But overall, there was a substantial reduction in self-reported outpatient visits. Patients were coming less often to the hospital for treatment, presumably because their diabetes was more stable. The number of patients reporting to emergency rooms also significantly decreased. No difference in the use of other healthcare resources, podiatrists or dietitians or educators, and also a significant difference in the number of days of work missed. Presumably, the emergency visits going down and the work days going down reflected the changes in hypoglycemia that I've just reported. So in the RYZE study, there was a significant decrease in hemoglobin A1C. I didn't show you the fasting glucose readings. They parallel the A1C and body weight. There was lower basal but higher prandial insulin dose overall, and numerical reductions in hypoglycemia and lower resource utilisation. So I thank you very much for your attention, and I'm very looking forward very much to actually taking any questions that you might have. Thank you very much for your attention.
Thank you, Professor Gregory. Now, in continuation to this talk, I would like to invite Professor A.H. Aamir to please come and enlighten the talk on the postprandial control with Ryzodeg and his experience sharing.
Thank you very much for the introduction. And I must say this is an excellent session. The reason I'm saying this is an excellent session because this was not planned by me. This was planned by Dr. Atif. I hope he's sitting here. Yeah, there he is. So thank you, Atif. It was a wonderful session. All the speakers, all the credit goes to you. Although I was a scientific chair, but this was all taken by Atif to take the responsibility for this session. So thank you for that. Excellent session. Two problems for me. Number one, they were excellent talks. But number two, I'm the last one. And you've got to go. So I'm going to be very quick, and I've just skipped a few slides. One, but I think I would request all of you that after this, there's a session on young active investigators, and to encourage them, all the research they have done, the younger lot. This time we had about 53 abstract, and we have selected 7. So I would request from this podium that please stay to encourage them. They're all young investigators from all over the country, so please encourage them. It's 10 minutes talk each. So I would request you to stay behind after the tea break. Right, I'm going to be talking very quickly, and I'll be talking about the importance of postprandial control. The learning objectives are challenging of glycemic control, importance of postprandial, which we sometimes forget. And although there are guidelines to suggest that you need to take care of postprandial, but we tend to continue working on a fasting and initiation. And one important aspect in both type 2 and type 1 is intensification. If you initiate and if you don't intensify, it looks like a failure in the making. Diabetes itself is expensive, but imagine if there are complications of diabetes, and this graph clearly shows that as the complication goes high, the cost of management of diabetes will naturally go high. That's not the only. There's a personal impact on the lives of people with diabetes as well, including from reduced physical health and relationships and work and office activities. All these are affected. We all know the guidelines suggest what we need to shoot for, and these are obviously flexible depending on what kind of patient you are looking at. And we also know that you reduce, and if you continue to reduce, you're going to see the improvement overall in the glycemic control and also overall in terms of reduction of the complications of diabetes, which I mentioned even yesterday in my talk, and Professor Mashur Alam mentioned that you need to work on prevention. Yes, we will work and we are working on prevention, but reducing complication of diabetes is equally important. So if it is so easy, what's the problem? The problem is when you achieve a glycemic control, there are issues related to that, including the hypos, the CV risk if there's a quick hypoglycemia, glycemic variation, and weight gain. What does the guideline say? We all are aware that there is a need to minimize the cardiovascular risk. We are all aware that we need to ensure that when we are treating, we need to have a lesser and less weight gain, minimize the risk of hypoglycemia, and increase the compliance. I think it is pretty clear for the audience sitting here that if you want to minimize the risk for cardiovascular, what are the drugs to be chosen, which are SGLT2 and GLP-1 receptor agonists. And then we need to ensure about minimizing the weight gain, how we can achieve that. And that again, we know that Wh2 molecules do that. But despite that, sometimes it is not enough. Risk of hypoglycemia, yes, there are newer drugs which will work and improve for type 2 in reducing the hypoglycemia. But if it doesn't work, then you need to step up your algorithm for controlling the diabetes. So ADA 2021 algorithm says you need to initiate with all these in mind on GLP-1 receptor agonist or SGLT2. But if it is not controlled, you need to insulin. We are all aware that insulin need to be basal insulin if you want to start. And that's a starting point. You cannot be controlling all the levels at one go. So we shoot for basal and we want to control the fasting first. But what we forget is that it's usually, once it's controlled, the A1C is still not coming down. And what's the reason for that? You need another insulin. And it is recommended in the guidelines that you need to add prandial insulin because it goes with the nature. Yes, it doesn't go with the nature as mentioned earlier by Jamal, that is not going through your portal circulation. But what we know now is the peaks related to meal and the basal insulin. Which is the largest meal that most of us have? Largest meal. Dinner. Somebody said lunch. We all have one major meal. And most often than not, it is the dinner, which is the evening meal, which is higher. So does this insulin Ryzodeg have a benefit in those cases? And does choosing this drug over only basal insulin will work? There is a science. If you have got a higher A1C, and this is important for the fellows who are sitting, if you've got an A1C around 10, what it shows is it's the fasting which is the major component. And no wonder we start people on a basal insulin because the major part is the fasting. But once you are improving, and as you come close to a 7, it is difficult, no wonder, to control the A1C or to improve further, because here, if you see, it's the postprandial when you're approaching close to 7. And this is often neglected, and this is often forgotten. And because of that, as I said, initiation is important. You should not miss the insulin if the need is there. But intensification of the same insulin is equally important. And intensification doesn't mean you keep on increasing basal insulin. It might mean that you need to add a prandial insulin. So if you've got this slide in mind, I think it will make easier. Most of us have got a clinical inertia. We don't want to do that. Basal is easy. One injection, it's easy. And we don't want to engage ourselves with that. But we all know that cardiovascular risk, apart from the lipids and blood pressure and all that, elevated blood glucose is one, and elevated glucose causes oxidative stress, impaired cardiovascular regulation, and structural changes to vessel, and hence it is a risk adding to cardiovascular morbidity and mortality. For the in the interest of time, I've cut my slides, and it's just one study which I'm going to present, which is relevant to us, which is a Boost Japan trial, which is post-dinner control, is important. And what they did was they injected IDAC as a one injection and compared it to insulin glargine 100 over the time. 81% of subjects were administered IDAC as prior to evening meal. So this was the, it's a very quick review. This was the inclusion criteria, standard one. So they were titrated against IDAC as with oral antidiabetics and insulin glargine 100. It was an open label prior to randomization. Other oral were there, and they administered IDAC as with the one largest meal. And in this case, it was mostly the evening meal, which is relevant, and that's why I included this in the presentation, that it is most relevant to our way of life, which is the evening meal as a major meal. What did they show? That over the time, the requirement of insulin remained the same. Remember, it's insulin glargine 100 compared to IDAC as. So the dose requirement remained the same. The A1C improvement was better because you are controlling probably postprandial as well with the evening meal. There was a reduction in A1C from 8.5 to 7% in the IDAC ASP, which was clinically and statistically significant. Did it cause more hypo? No, it didn't. And that was one of the major benefit, but that was clinically less, but not statistically significant, less hypos. So the summary of the Boost Japan results showed that IDAC ASP resulted in superior A1C, and you've just heard from Professor in Australia regarding the real life evidence, and that was again for the same insulin that resulted in superior A1C reduction compared to insulin glargine, which was clinically and statistically significant. The rate of confirmed hypoglycemia was numerically lower with the IDAC ASP, and the rate of nocturnal confirmed hypoglycemia again was numerically low. Dosing, it is for type 1, it is simpler. You start with the main meal, but because for type 1, you need to have a prandial, of course, for the other meals. That has to be done. And for type 2, again, you can administer with the main meal, and then you can have a combination of orals, you can switch or increase or decrease the dose as the need may be, going 2 up or 2 down as and what is required for your patients, depending on what target you want to achieve. Which patient would benefit? Varying stages of beta cell dysfunction, usually late in the course of type 2 diabetes at least. Patient who need to start insulin or switch from another basal insulin. When hypoglycemic, multiple injection and lack of flexibility are barrier. When patients have got an irregular lifestyle. So if they've got a one major meal, you can start this insulin for a better outcomes. When fasting and A1C are not at target, but when fasting and postprandial, particularly with the largest meal, are not on target, you can start IDAC as for these patients. So in summary, IDAC as has got a better control in terms of A1C, lower insulin dose, fasting and postprandial both are controlled, and the simple intensification option and flexible dosing for basal bolus therapy. In the context of this session, I have picked up 2 words from this session. One was by Dr. Jamal. He said equity. Very important word, equity. I think in the context of this session we are talking about. And the other was Abbas mentioned about will. So if there's a will, there's a way. I'm thankful to Dr. Basit that he'll be joining us next door for signing the MOU. In the context of today's session in KP, we have Insulin for Life program in KP. More than 43,000 patients are registered on the net on a software developed by USAID and us. We are giving to 28 districts free insulin. All type 1 are receiving glucometers and testing strips. Because just by giving insulin and not monitoring is not good enough. We are giving type 2 patients orals, insulin, antihypertension, and anti-lipid, lipid-lowering drug, because we know all these are risky. And now we are about to procure and give to all the pregnant and young type 1 analogs if they are prescribed by the physician. So the last point I mentioned for the equity, we sometimes feel that why XYZ can get an analog and a poor child can't. So now we are going to the equity. So my point here is that yes, if there's a will, there's a way. And I hope it replicates to the whole country. I really wish and hope for. Thank you very much.
Thank you. We can have a couple of questions. Yes, Raja.
Thank you, Dr. Aamir. Very well explained. Professor Gregory is live with us. And Professor...
My question is to Professor A.H. Aamir. As usual, your presentation is excellent. My request is to comment on your personal experience of ID blood, Ryzodeg ke baare mein. Personal experience.
Right. Personally, yes, it fits good with some of our patients instead of basal insulin. But again, I cannot give a dogmatic statement that no, it fits everybody. It doesn't. It will not. So that's why you cannot have a blanket statement for everybody. I cannot give a dogmatic statement that no, it is good for everybody. So yes, for some patients it is better, and it's better to switch from basal if they've got basal insulin only, if they've got a larger meal chunk and they don't want a second injection. So it works well.
Yeah. My question is to Professor Greg Fulcher. Professor Fulcher, I'm a Dr. Aamir Raza. I'm an endocrinologist based in Islamabad, and my interest also are real world experience. And we are, I mean, from Islamabad, we do have a real world experience for Ryzodeg on about 105 patients, and it's been submitted in incoming December IDF meeting as a poster. And one thing that really struck me was, because initially when I look at the data, I thought maybe there might be glitches in my data, was this weight loss of around 1 kilogram. And then I look at your data in the RYZE, and I actually mentioned that in my poster in IDF, because your data was pretty much the same to the data from Pakistan, which is about HbA1c reduction of 1.6% and a weight loss of around about 1.1 kilogram. So what do you think in your mind is the reason behind that? Because what I was thinking was, maybe is it like similar to Levomil, which is we knew is more hepatoselective, and there is some weight loss data with Levomil as well, because we knew the longer the insulin is or more hepatoselective it is, or whether do you think this is because of less glycemic variability, and with that there will be lesser insulin units with say Idegrera, and maybe that might contribute to that weight loss of 1 or 1.2 kilogram?
Yes, no, it's interesting, isn't it? And we've done a number of presentations of this data in different countries, and the same comments have been made. We don't think that it's anything specific about the pharmacokinetics of the molecule itself. So we don't think that's the explanation. I think the explanation that you suggested, I think, is one that has been discussed, and we think that that's reasonable. I think that the reduction in hypoglycemia, I think, is important, and that we've been able to keep roughly the same sort of insulin dose without having to put up the dose a lot. And I think that that makes a difference as well. And the fact that as you say, you've got less variability over the course of the day, and I think that makes a difference. So we don't really know, but the views that have been put forward about this are very similar to the suggestions that you've made. But no, we don't think it's a specific factor of anything about the molecule itself in terms of any direct effect.
Thank you. I will have to, in the interest of time, finish off the session. I request the two chairpersons sitting along with me to give their single-minute comments, please.
Assalamu alaikum. Bismillahirrahmanirrahim. Nahamduhu wa nusallihi ala rasulil kareem. In the presence of two giants, I think I feel very small to give the comments on these things. They are the authorities on the management of type 1 diabetes, mellitus, and even type 2. So first of all, I'm thankful to the organizer for inviting me over here. Second, the level of presentation were excellent. All speakers spoke loudly and clearly on all the aspects. डॉक्टर आतिफ की जो दिल की कुड़न मुझे जो नज़र आई कि जो टाइप 1 डायबिटीज़ के पेशेंट्स के लिए वो करना चाहते हैं, आई थिंक अल्लाह हमारी दुआ है कि अल्लाह ताला उनको इसमें पूरा करे। और जो सबसे इम्पोर्टेंट चीज़ है मैंने जो इसमें लर्न किया है, इट्स द एजुकेशन ऑफ द masses, education of the doctors, healthcare professionals, then education of the patient and their attendant. To give you an example, मेरे पास आज से 20 साल पहले एक हमारे हॉस्पिटल के कंसल्टेंट हैं, उनके बेटे को टाइप 1 डायबिटीज मेलाइटिस हो गई और उसको मैंने इंसुलिन शुरू की। एक हफ्ते के बाद फॉलोअप के लिए आया तो मुझे कहने लगे, डॉक्टर साहब जब वो मेरे बेटे के टीका लगता तो उसके वहाँ सबकुटेनियस इंजेक्शन नहीं लगता, मेरे दिल के अंदर इंजेक्शन लगता है, टीका लगता है, सुई लगती है। कहते मुझे इतनी तकलीफ होती है जब उसको होता है। And now he is that son became doctor and then he went to USA. He is consultant in USA nowadays and he is on insulin pump nowadays. तो ये जो है बड़ा इंपॉर्टेंट है कि उस वक्त पेरेंट को एजुकेट करना। वाकई जो डॉक्टर अब्बास रजा ने बताया कि जी पेशेंट के पेरेंट्स ज़्यादा क्राई कर रहे होते हैं एज कम्पेयर टू द पेशेंट। दूसरी चीज़ बात हुई थी प्री मिक्स इंसुलिन की टाइप 2 डायबिटीज मेलाइटिस में। आई थिंक दिस इज़ वेरी इंपॉर्टेंट। मैं आई वाज ट्रेन्ड विद प्रोफेसर मैजी IDC इंटरनेशनल डायबिटिक सेंटर मिनेसोटा से आए थे, तो उनके साथ ट्रेनिंग हमारी हो रही थी। तो मैं टाइप 1 पे प्रेजेंट कर रहा था कि पाकिस्तान में हाउ डू वी मैनेज टाइप 1 डायबिटीज मेलाइटिस। तो मैंने उन्हें बताया कि वी आल्सो मैनेज टाइप 1 डायबिटीज मेलाइटिस विद प्री मिक्स इंसुलिन। एंड आफ्टर दैट for 3 days he used to make fun of me that my friend in Pakistan is managed mellitus with pre-mixed insulin. So pre-mixed insulin सिर्फ उसको कीटोएसिडोसिस को प्रिवेंट कर सकती है, बट इट डजंट कंट्रोल द ब्लड ग्लूकोज। जैसा हमें टाइट ग्लाइसीमिया चाहिए होता है, हाइपो और हाइपो दोनों चीज़ें इसके साथ होती हैं। तीसरी चीज़ जो सी है ना, मेरा ख्याल है हम सब लोगों को मिलके एक जो सी सेल्फलेस जो सी है ना वो एफर्ट करनी चाहिए, सबको मिलना चाहिए। वी शुड ज्वाइन है, इंडिविजुअली सब लोग कर रहे हैं और पेशेंट का लोड बहुत ज़्यादा है। और वाकई जो इक्विटी वाली बात है ये सबसे इम्पॉर्टेंट है, क्योंकि मैं एक छोटा सा शॉर्ट क्लिनिक रन कर रहा हूँ, चैरिटी क्लिनिक डायबिटिक पेशेंट का। और टाइप 1 डायबिटीज़ की एक फैमिली के मेरे पास 4 बच्चियाँ हैं, 4 बच्चियाँ जिनको टाइप 1 डायबिटीज़ है एंड दे हैव नो रिसोर्सेज। उनको हम ग्लूकोमीटर भी प्रोवाइड करते हैं, स्टिक्स भी प्रोवाइड करते हैं, लेकिन यहाँ इस्लामाबाद, पिंडी और पंजाब में भी ये जो है जिस तरह डॉक्टर आमिर बता रहे हैं कि दे हैव एक्सेस टू द इंसुलिन एंड ग्लूकोमीटर स्टिक्स बट इट्स नॉट अवेलेबल। तो ये बहुत बड़ा प्रॉब्लम्स है और यहाँ पे तो आई थिंक हम सबको भी जॉइंट हैंड एंड इंशाल्लाह वी विल डू समथिंग फॉर इट। और उसमें सबसे इम्पॉर्टेंट चीज़ है कि सब अगर गरीब बंदा है ना, वो ये किस तरह कहते हैं ना, मर्सिडीज़ और मेहरान भी लाहौर पहुंच जाएगी। हो सकता है कि उसमें ठंड ज़्यादा लगे, उसमें झटके ज़्यादा लगें, लेकिन लाहौर वो भी पहुंच जाएगी, मर्सिडीज़ भी लाहौर पहुंच जाएगी। तो जो गरीब बंदा है ना उसको मेहरान ही दें, उसको मर्सिडीज़ ना दें। जज़ाकुमुल्लाह खैर। अस्सलाम वालेकुम।
Thank you. I think that sums up really. I mean, apart from the word that equity that has been come up in the session, I think there's one more word that I would like you to leave with is the holistic approach. Sometimes we get too engrossed in the micromanagement of insulin and the type of insulin, and we forget about the totality of the situation. So I think whoever is managing, especially pediatric children, when we talk about children, then the totality of the care, I think, is extremely important. Thank you. I would just leave with that comment.
I think we'll finish off here by thanking the speakers and the people who participated in question answer session actively, the whole audience, the sponsors, the organizers.
Shield distribution is there. I request Professor Abdul Jabbar to come here and kindly present the shield to the chairs and speaker. Dr. Atif Munir, kindly come to the stage and receive your shield of appreciation. Professor Jamal. Professor Jamal Zafar. And for myself.